Good afternoon, everyone. Welcome back to our afternoon session. And I have to say, I don't think I've been as excited for any session as I am for this one. When in 2016 or 17, when I first started thinking about this conference, the idea was that there were many companies interested in developing medicines for the diseases we treat. And you can see now, so many years later, is that's just expanding. We're really lucky in dermatology and the dermatology rheumatology space to have so many companies interested in developing novel medications to treat the diseases that we see on a daily basis. But when you think about this explosion of activity introducing novel medications, really the only reason that that occurs is because of breakthroughs in medicine, in dermatology, breakthroughs in defining diseases, breakthroughs in understanding the immunopathogenesis on a cellular and molecular level, breakthroughs in thinking about unique ways to try to treat patients who suffer from these diseases. And this afternoon, what we're going to do is we're going to celebrate those breakthroughs that pave the way for the development of medications that ease suffering in our patients. Some of the breakthroughs that you will hear about this afternoon are already ingrained in your everyday practice, so much so that you probably don't even think about how they came to be discovered and be accepted in medicine. Others are extremely new, still evolving, and I think it still remains to be seen how much they will be ingrained in our everyday practices. But without question, they are all extremely important breakthroughs, and I cannot tell you how excited I am for these speakers to agree to come here and tell us these stories. So with that being said, how many people have ever heard of subacute cutaneous lupus erythematosus? Okay. How about amyopathic dermatomyositis? Well, you have our first speaker to thank for knowing those diseases. Dr. Richard Sontheimer is currently a professor of dermatology at the Spencer Fox Eccles School of Medicine at the University of Utah. He has been successfully involved in patient-oriented translational clinical investigation for 42 years at 4 USA academic medical centers, starting at the University of Texas Southwestern Medical School in Dallas in 1979. His career-long clinical and research focus has been on the etiopathogenesis and clinical management of the cutaneous manifestations of autoimmune connective tissue diseases, especially lupus erythematosus and dermatomyositis. And I could spend an hour reading off all the accolades that he has received over the course of his career. But instead, I'd like to invite Dr. Sontheimer to tell this story, the story of subacute cutaneous lupus and amyopathic dermatomyositis. Dr. Sontheimer.
Thank you, Tony. Lovely introduction. I've been charged to kind of go back in time with you today on these, the conception of these two different clinical entities, kind of going back to the 1970s and then working our way up to today and how we view them. It'll be a little personal. At the beginning, it was just a couple of people crazy enough to try to convince the dermatology audience that we should be thinking a little bit differently about these conditions. But it's been a rewarding time, and I've been very fortunate to be involved with some really bright and very good mentors along the way in this process. No conflicts with this presentation, I do not believe. The objectives are to kind of review the origin of these clinical concepts, SCLE and clinically amyopathic dermatomyositis, And I was also going to include that some over-the-horizon looks at what I think, at least, are very exciting things going on and potential treatment, but you've already been shown those thoughts earlier today, so I'll skip past those slides. A little bit challenging subject. This is a timeline from PubMed of these two subjects, and together they account for about 1,500 publications. So if some of you in the audience were involved in some of these publications, and I don't mention them today in my presentation, please forgive me. It's a little broad subject in that regard. So we'll start off with evolution of thought concerning idiopathic SCLE and then drug-induced SCLE. And that story starts with my mentor at UT Southwestern in the 1970s, Dr. James N. Gilliam. Rather unique individual. He was an assistant professor there starting, I think, in 1972, but his prior training was really quite wide. He was board certified in internal medicine, in dermatology and rheumatology, and he was board eligible in dermatopathology as well, but never took the boards. And I really think that kind of cross-current learning that he did, going in those different directions, kind of gave him some insight in terms of this, the subjects that we'll be talking about today. Wonderful mentor. I joined him as his first fellow after finishing my internal medicine residency at the University of Utah in 1976. And he had been thinking about this, the group of patients since he started on the faculty there. And he found them very confusing. Patients who had these upper body, very photosensitive, papulosquamous skin changes showing interface dermatitis on biopsy, not thought to be drug-induced, and these patients were often ANA positive, and he really conceptualized these as a part of the cutaneous LE umbrella. And as you will see, people before him talked about these patients, but we basically had no data on them in terms of what it means to have that type of cutaneous LE presentation. Historical literature, Hutchinson, Brock, both, if you look at some of their readings, kind of describe these patients as under the umbrella of cutaneous LE. But Dr. Gilliam didn't feel that any of those things really, they were historical. They weren't relevant in 1972 medicine. And so he was brave enough to form this new concept, subacute cutaneous lupus erythematosus, first published it in this interesting review that was published in the Continuing Education for Family Physician Journal, something kind of off the wall. But it was his view of the cutaneous LE concept that he had at that time. But he put SCLE in with the acute cutaneous LE into the spectrum and the chronic cutaneous LE into the spectrum. Those two ends of the spectrum pretty much dominated up until his thinking. He thought that these patients kind of fit halfway between the two ends of the spectrum of lupus erythematosus in terms of clinical expression. Today, I would move the SCLE box to the right on this slide. 50% of the SCLE patients that we originally reported had 4 or more of the American College of Rheumatology criteria for the classification of systemic LE, but they were the musculoskeletal hematologic features. They weren't the lupus nephritis, the CNS lupus. But those patients did have a little bit more going on outside their skin than the typical classical discoid LE patients. So he put them in the middle. There were a lot of other designations that you could find in the literature that basically were referring to SCLE as we understand it today, and those are shown on the bottom of this slide. But that wasn't very helpful. You've got a bunch of things that people have, reported, but we don't know what that means. And that's why he felt justified in formulating this concept of subacute cutaneous lupus. But we'll have to admit there was a lot of controversy created by that that showed up in different ways. This was the first report. It was in 1979. My first project when I joined his lab was on some immunofluorescence microscopy kind of issues related to double-stranded DNA antibody assays. And I didn't really know. I was like 3 months after I'd started this research thing, because I'd never done any kind of research before, if that was really going to be the right thing for me in the long run. But I got hooked pretty early. And I think that's important for fellows. Don't put them on the hardest project in the lab the first month they show up. So this was a retrospective analysis of the clinical and lab features of 27 patients having this clinical set of skin changes. Again, thinking that it was somewhat of an intermediate marker for active systemic LE and damage. These were some of the patients from that cohort. I've got 2 men here, but actually it's much more common in women than men, like all forms of LE. But you're very familiar with the variations on the theme. They're annular and papulosquamous subtypes clinically. That doesn't seem to make any difference in their clinical features and their outcome or treatability. There is some forms that can kind of go into blistering, cleavage of the dermal epidermal junction that can look like TEN, or the TEN-like subacute cutaneous LE patients that we find in the literature. So at that time, the thinking was this non-scarring, highly photosensitive form of cutaneous LE was often ANA positive. What made it different from classic cutaneous LE, discoid LE, 50%, as I've mentioned, had these classification criteria for SLE. That would have been helpful if these new drugs would have been available back then, because then we would have gotten belimumab right off as soon as it came to the market. But the associations, Sjogren syndrome is associated with this condition more so than active, severe internal systemic LE, and we'll talk more about that. And a good response to the immunoquivalent antimalarial drugs. But that was just, that was kind of one person's thought about this group of patients, and there was a lot of debate about this. We went on a couple of years later to have a collaborative interaction with Morris Reichlin's lab, who was then in Buffalo, and Peter Stastny, who was the HLA immunologist at UT Southwestern at the time, to look at if there were any serologic or HLA markers for this subset. And as we found, the original studies, 63% of the SCLE patients in that original cohort had Rho-SSA, LA-SSB autoantibodies in the most specific form of assay that would be counter-immunoelectrophoresis. By ELISA, later studies showed that probably 80%, 85% of SCLE patients were Rho antibody positive. And interestingly, Peter Stastny's work showed a really enrichment for the HLA B8DR3 HLA type. And it seemed like there was a real strong correlation between the Rho antibody status and this HLA B8DR3 status. And that brings up the 8.1 ancestral haplotype. Approximately 15% of you sitting in this room have this HLA haplotype. And it's got, multiple genes that are linked that do different things, but one of the most important things they do is the kind of immune responsiveness they give you. They give you a little hyperimmune responsiveness, much like the mice in the research lab. You got low immune responder mice and you got high immune responder mice based on their genetics. This was what we were seeing in these patients. Their immune system seemed to be genetically programmed to be kind of ready to go before other people's immune system responds when meeting a specific stimulus. And this HLA serologic background puts these patients at risk for the various end organ autoimmune diseases, as you see listed on the bottom. So there's that linkage between SCLE and those other conditions. The controversy. Probably the SCLE concept would be dead by now. You wouldn't even be using that term had it not been for the fact that there was this blood biomarker that people could actually use clinically in the 1970s that kind of added to the clinical similarity of these patients. There's a biologic marker. And, you know, immunology was brand new in the 1970s. We were just discovering pemphigus antibodies and things like that. So that really kind of, plus other people started to report these patients, similar clinical findings, similar antibody status. So I think that was the thing that really solidified that concept. However, the controversy was very vigorous up until that point. And I think it was even responsible for one death. Now, this is an anecdote. I have never heard it independently verified, but during an ADA meeting on Hawaii, there was a discussion of skin lupus and SCLE, and there were half the audience said, "Yeah, this is an interesting concept." The other half said, "This is BS. You know, we don't need a new name for this. Everybody's seen this before." So one of the people involved on the contra side was John Knox, and he was at that time the chair of dermatology at Baylor in Houston. He had a heart attack during this tirade over SCLE, and he died. We hold on to our concepts that we learned when we were young. You know, you're going to have to prove to us that there's a better way of thinking, and it takes a while sometimes to do that. John hadn't quite got to that point, unfortunately. So these were my Camelot days in medicine, the years that I look back on more so than any other years during my career with great joy and gratitude. That's me on the left in my afro hairstyle days. Dr. Gilliam is the chief with tall feathers. Paul Brickstresser was the vice chair of the division at that time. It was not a department until the early 1980s. And Mike Tharp is on the right. Mike did his derm training at Duke and came to our faculty as a junior faculty member. And such a really good group of people who support each other and have a lot of fun together. This was a picnic, a departmental picnic at Dr. Gilliam's home during one of those years. Unfortunately, Dr. Gilliam passed away early. He died in 1984 of a very aggressive form of prostate cancer. He would have been a giant of our specialty had he had a normal lifespan. He was a natural born leader. We lost a lot with his early death. I had an opportunity to kind of review his work in a more specific way, and that was published in 2018. Okay, drug-induced SCLE. After we had reported the original data, the people at University of Colorado at Denver, Clark Huff, David Norris, that group, reported 5 patients that had SCLE, as was known at that time, who seemed to have it triggered by hydrochlorothiazide. When they stopped the drug, skin changes went away. When they challenged one patient and the SCLE lesions came back. And they only checked in 3 patients whether the Rho antibodies disappeared. It was only one of the 3 they tested where the Rho antibodies went away. And that's not really surprising. Since that time, a number of other drug classes have come online as being responsible for maybe bringing subclinical SCLE and a high immune responder human type up to the surface as clinical disease. And that group of drugs, aphthiazides, calcium channel blockers, ACE inhibitors, cardiovascular drugs, later terbinafine, protein pump inhibitors, and then the biologics, TNF-alpha inhibitors especially, and then more currently, both traditional chemotherapy and immune adjuvant type chemotherapy, immune checkpoint inhibitor therapy that we're all grappling with all of our new cases of drug-induced everything in the skin. So it's, when you have classes of drugs, you kind of think, well, if this class of drugs does something, then it triggers it. But why do so many classes of drugs? How can we explain that? This is a list, a fairly current list by Vicki Worth and her group of drug-induced SCLE literature, which is mostly SCLE rather than other forms of cutaneous SLE. And you see there's many, many more drugs and drug classes. Protein pump inhibitor is, there's that silent disease, a silent thing, because it's over the counter now. And you look at somebody's medication list, no, you're not, they're not on that drug. And then you ask them, yeah, I've been taking that drug for 15 years, So one group did a nice review of protein pump inhibitors and gave us a little bit more information. Older individuals, that was recognized in our original cohort. It was the median age for the original idiopathic SLE group was in the mid-40s, where it was 50 to 60 range in the drug-induced patients. Incubation period, about 6 weeks. In drug-naive patients, took about 6 weeks to start seeing elements of SCLE. Stopping the drug, they all got better in a median of 4 weeks. Again, 83% had Rho SSA loss SB antibodies. And the reports, this was a literature review in some of their cases as well. But some patients had started with SCLE and had antibodies with drug-induced SCLE, and that antibody went away, but probably more cases, the antibody was still there after the SCLE lesions had resolved and the drugs were taken away. And that's probably because these antibodies that we use clinically as markers, these antibodies take a long time to surface clinically. This is a study from John Harley, Judy James at the Oklahoma Medical Research Foundation, and they got hold of the military blood bank, where blood samples on every soldier is stored away in liquid nitrogen. And so they had a group of individuals who had SLE, and then they had their blood 5 years before they developed clinical SLE. And they looked at the antibody status, and this is what shows you. There's this slow creep between 5 and 10 years before clinical disease. There's this buildup of antibody, and then disease starts. So it'd be surprising to me that the antibodies would all go away if you just stopped the drug that was triggering SCLE. Again, some thoughts we had 10, 12 years ago, when this list was not quite as long as it is now of drugs that induce SCLE. We superimposed the drugs, individual drugs that are known photosynthesizers, like hydrochlorothiazide. The idea came up, could this be connected etiologically? Is drug-induced SCLE an example of photo-induced isomorphism? Can a photosensitive drug reaction induce SCLE via Kebner response in an immunogenetically predisposed host, i.e. the high immune responder, HLA-B8DR3 people? But we know now that that's just one side of the story. A lot of drugs that are inducing SCLE more recently, particularly the cancer drugs are not photosensitizing drugs in a traditional sense, but they are definitely inducing SCLE. So the unanswered questions for idiopathic and drug-induced SCLE at this point in my mind, there's been a handful of case reports of SCLE occurring in a paraneoplastic fashion associated with maternal cancer. I looked recently, it's just only 7 case reports that I could find. So, and that might be due to the drugs that they were being given for their cancer might actually have induced the SCLE more so than there being an association between SCLE and cancer. And an important issue still is the relationship between Sjogren's syndrome and SCLE. About a 20% overlap. This was a recent study and a review of the literature on this subject, and it goes both ways. It can be, I think there are more patients who have primary Sjogren's syndrome that end up with SCLE later, but the opposite occurs. There are certainly patients, some of which I've seen, who have SCLE for quite a long time, and all of a sudden they come up with one of the complications of Sjogren's syndrome. I had one man was doing really well in animal aerial therapy for a couple of years. He came into clinic, he was wheeled in by his family in a wheelchair, and he'd never had any muscle problems. He had flaccid weakness in all of his muscles. He had developed interstitial nephropathy, which is one of the complications of Sjogren's syndrome, and his potassium level was like 2.9 or something. And when his potassium was repleted, that was due to the interstitial nephropathy. His weakness all of a sudden disappeared. So there are some of those complications of Sjogren's that kind of lurk in the background of patients with SCLE that I think you at least should be aware of. Neurological problems, cognitive problems occur in Sjogren's syndrome, and that occasionally has been seen in SCLE. Okay, we're going to bounce over targeted therapy because it's really been, in both Dr. Kahnberg's and Dr. Fiorentona's presentation, have covered all the things I was going to talk about in that regard. This CAR T-cell therapy, to me, I've been kind of doing this for a long time, approaching 50 years, seeing patients with these diseases. And you see one anecdotal report that comes up and, we've cured systemic sclerosis. And somebody does a clinical trial and it's worthless, and I've been seeing that, for pretty much every year in my career. We need a cure, We're just treating the symptoms of these diseases. Now, we're doing better at that. We're giving people better quality of life with modern therapy. But do we have to put up with autoimmunity? Is there a way to turn that off, to selectively? And this has given, this new approach has been very intriguing in that regard because, it's just a handful of patients that have been reported so far. It's a brand new thing. First publication was 2022. But it's been, every one of the patients treated has had a full remission. And these were people near death, young people. I think the first report, the average age was 22 years of age. Bad lupus nephritis, CNS lupus. They've all had a drug-free remission after a year to 15 months. Now, it's still short-term, yes, but that gives hope. And that technology could lead in a number of different ways to help people with these diseases, and not just the connective tissue diseases. It could be myasthenia gravis. It could be any autoimmune disease, humoral, where there's evidence of humoral significance could be modified by this treatment approach. So that's all I'll say about CAR T. Okay, here's another heliotrope flower. We're going to switch over and talk about clinically amyopathic dermatomyositis now. Hallmark skin changes, you're all familiar with, and those are seen in both classical and clinically amyopathic dermatomyositis. We're going to talk about some atypical vasculopathic features that go along with dermatomyositis that we don't see routinely associated with the hallmark changes. But most of the patients with amyopathic dermatomyositis I've seen, their skin changes have been the classic hallmark changes. I think it's the vasculopathic ulcer patients are a small percentage overall. Long timeline on this. The concept of dermatomyositis sine myositis has been around for a while. And that was used for these patients, the patients who had skin changes that dermatologists could look at and say, well, this is dermatomyositis. Other things in dermatology don't cause this set of skin changes, but they were not weak for 6 months or 2 years or whatever period. They were mostly just skin problems, and they were never accepted to be dermatomyositis patients by other specialties of medicine because the definition of dermatomyositis had to include evidence of muscle inflammation and muscle weakness to some extent. So dermatologists knew about this. They'd see these patients, but nobody ever really knew what to do with them. There was never any studies that you can find in PubMed about dermatomyositis in terms of what the risk factors are and best management strategies. So that led up into the modern times to 1975 when a rheumatologist, Lawrence Crane, published a series of 6 patients that had what he said, they had cutaneous dermatomyositis, but they had no muscle weakness. And he followed these patients over time, but they all eventually developed muscle weakness and therefore had a definition of classic dermatomyositis. But they all had these long periods before they ever developed clinically significant muscle inflammation. Interesting things in that, there was no malignant disease in these patients, and then 2 patients ended up with pulmonary fibrosis, which was kind of interesting. Dr. Gilliam passed away in 1984. I inherited his practice, his connective tissue disease practice of patients. And he taught me when I was working with him, he thought, like Lawrence Crane did, that these patients all were going to get classic dermatomyositis. So his approach was to hit them hard early. We could recognize, 6 months, the patient has these hallmark skin changes, no muscle weakness. We're going to treat them aggressively to try to mitigate them going on to bad muscle disease. So that's kind of how I learned, but when I started caring for his patients and the new patients that I would see there at UT Southwestern, I'd see people coming in that has these skin changes for 20 years, and we worked them up for myositis, and they had no evidence. They were not weak. And so I began to think, maybe that's not the right way to treat these patients, just to aggressively treat them with immunosuppressive therapy just because they have the skin changes. That some of these patients do pretty well over time. So working with one of the dermatology residents at that time, Rebecca Ewer, she was looking for a project to work on with me, and I suggested this, and she's one of these kind of bulldog type residents. You just point her in the right direction and stand back. It got done quickly. She's now a senior, highly respected practitioner in Dallas area. She was, she had seen everything that I knew about it at that time. I just told her to go find out and read and catch up. And she said, well, we need to bring attention to this. There needs to be some information about these patients that other clinicians can use. And this dermatomyositis concept's been around for decades, and it hasn't served that purpose. So she insisted that we come up with another name. We tried several things out. I suggested to her that this concept of amyopathic dermatomyositis, maybe we could use that, because we gotten kind of hit hard by the rheumatologist with the SCLE concept, and I didn't know if I wanted to go up against that wall again with the DM concept. So Carl Pearson was one of the major academic rheumatologists at UCLA in those years, and a couple of decades earlier. in terms of dermatomyositis, in terms of understanding and treating dermatomyositis. And I saw one day in his textbook where he actually used this term. He says, I saw a couple of patients that had the skin changes, but they never developed muscle disease. And so I said, we can at least blame it on a rheumatologist, you know? And Dr. Pearson came up with this. Actually, there's a few hits in PubMed of going back to the 1950s where this term had been kind of thrown around a little bit. And we know that people have been thinking about these patients for a long time prior to that. It was just no systematic evidence was available to help us take care of those patients. Again, controversy arises with new concepts for old conditions. Dermatologists just didn't think we needed to do this. Says, let's just study dermatomyositis and amyositis. But like I say, I didn't have a choice. Dr. Ewer did not give me a choice on that. Rheumatologist, said if you didn't look hard enough to see if they had muscle inflammation, if you had done EMG, if you had done muscle MRI, muscle biopsies, you'd have found that they had muscle inflammation. Well, yeah, that might be true, but they were totally unweak for years. So what does that mean? That's subclinical. That doesn't help us in managing the patients, right? So, but there was a lot of discussion along those lines. So we said, okay, let's do this. Let's try to tamp things down a little bit by the concept of clinically amyopathic dermatomyositis. Okay, we didn't do all the muscle testing, but these people are working. Some are exercise instructors, and they've been that way for years. So they're clinically amyopathic. And I think that's a better way to think about this, although most all of the world now is going back and using the original term, amyopathic dermatomyositis, as we talk about things like, interstitial lung disease and MDA5 antibody. But I think clinically amyopathic dermatomyositis is a more precise term. In a review that I put together, I think it was Dermatology Clinics, I made the bold move to try to formulate some criteria for the skin changes. And this would be to help people with studies of this, because you can't just go to a pharmaceutical company and say, I've got this skin rash that we want to do this trial on, and the global assessment's our endpoint, they're better or not better. That doesn't work with the FDA. So you have to have some criteria to document that there's been some movement in terms of the effect of a treatment. So had to have the hallmark skin changes, biopsy confirmation of interface dermatitis, and the major minor criteria. And this is pretty weak, I admit, but it was with the hope that it might stimulate some systematic study. Nowadays, we do this now in large groups with medical associations get together and have lots of experts and based on a lot of patient care, but we didn't have that kind of interactive activity back then. And so people are now using Sondheimer's criteria. I didn't name it that, okay? But as they write about amyopathic dermatomyositis patient getting interstitial lung disease, and having MDA5 antibody and dying, even with the best of intensive care, because it's a very, very difficult situation clinically. People studying that at least have this starting point, but there needs to be more systematic study there, obviously, at this point in time. The other dermatomyositis is expressed clinically in different ways in different ethnicities in different countries. Interstitial lung disease in America population is typically it's been about 10% risk over time, but in Japan it's 40%, and that part of that might be the fact that their healthcare system, if anybody in Japan gets a diagnosis of dermatomyositis, they get admitted to a hospital and the full workup is done, including interstitial high-resolution CT exam of their chest. So they really jump on this early. So there could be a bit of a bias there. But they were starting to see patients with this skin-only form of dermatomyositis get really sick with interstitial lung disease and pass away, even with aggressive treatment. And this really hasn't circulated in this country much at that point. So with Sachiko Miyagawa and I wrote a letter to the editor of the JAD about this, that we as dermatologists ought to at least be aware of this and be on the lookout. Again, the amyopathic dermatomyositis concept would have probably died had there not been a biomarker for it developed. And that's the what we now call the MDA5 antibody. But at the time, a group of Japanese workers led by Shinji Sato found in these amyopathic patients in Japan this antibody, 140 kilodalton molecular weight, that they named CADM140. But later, that antibody was shown to be identical to a previous antibody that had been described under the MDA5 designation. So the MDA5 is what's stuck for this antibody that occurs in amyopathic dermatomyositis patients and carries a very aggressive risk of doing poorly. Well, I was at the University of Iowa for about 5 years, working with the residents there, just did a couple of reviews because this concept was still fairly nascent at that point, just looking at the literature of adult onset amyopathic dermatomyositis and juvenile onset amyopathic dermatomyositis. And that's kind of where we are today. The issue now is management of these patients. What does it mean? And what do you do when they get sick? What scares me the most still these days, after seeing these patients for a long time, is the risk of clinically amyopathic or classic adult onset dermatomyositis developing rapidly progressive interstitial lung disease and getting out of happening so quick, there's almost not much time to do it. I'm aware of a young male physician in Canada who developed this, and he was in a hospital setting and got started on aggressive treatment very early and died from it in just a couple of months after onset of the skin changes. So the MDA5 positive amyopathic dermatomyositis subgroup is a disease that often will be seen first by one of us, a dermatologist, not by rheumatologist, not by pulmonary medicine specialist. We see the skin changes, and that can be very important at getting the patient going in the right direction of risk factors. We do the blood test. We see if they have MDA5 antibody, and if so, we're going to be very careful with them. We're going to get a baseline, probably a baseline chest, high-resolution chest CT to see what their pulmonary status is before it starts to go bad. It helps you focus the appropriate oversight and ready treatment when that patient starts to show evidence of clinically relevant interstitial lung disease. Yeah, alluded to this earlier, Dr. Fiorentino and his colleagues at Stanford pointing out that there's some of these atypical skin changes that can be a clinical marker for this subset of patients with this particular antibody specificity. These punched out ulcers that you see over the hands, vasculopathic ulcers. Now, we've always known that, that's a risk factor to occur in just dermatomyositis in general. But David taught us that this is one of the clinical signs we need to be on the lookout for patients having an increased risk for going on to really bad interstitial lung disease. Just a recent report from Japan suggesting that one of the classic hallmark changes of skin, the nail fold changes that we're all familiar with, that they said that kind of hemorrhagic crusting that we see in this picture is correlated in their studies with the MDA5 antibody status in amyopathic DM patients. This photo is actually a photo I took 2 weeks ago of a new patient that I saw that we're still working up, but she was MDA5 antibody negative, which is good for her. Again, as dermatologists, I think we can play a very important role, not in coming into the ICU in middle of the night to try to help them with their lung failure, but helping try to, try to prevent them from getting that bad or having their pulmonary function, if it starts to go down, getting them to the right people as quickly as you can at that point. I think this hemorrhagic crusting are these little cuticular hemosiderin deposits that under dermoscopy you can see that occur in the cuticle due to the damaged blood vessels, small vessels, and leaking red cells out into this avascular area. Okay, so I work in the United States, and so the patients I see, I have to think about them in the context of Americans and how Americans how they express dermatomyositis compared to people, say, in Asia. And I found this study very helpful. It was published in 2017. A group of investigators at University of Pittsburgh rheumatology group, where they just matched up 61 patients with, they had seen with classic dermatomyositis, 61 patients with clinically amyopathic dermatomyositis. And interestingly, it was 13% on both populations had MDA5 antibody. Okay, what happens to those patients, those two patient groups? 50% of the MDA5 antibody positive amyopathic DM patients went on to rapidly progressive interstitial lung disease. So, and that was a much higher rate than the classic dermatomyositis patients with MDA5 antibody. Risk factors for having bad outcomes in this situation. Again, this is going to be more the pulmonary medicine importance, but trying to see if there's any signals that can kind of help us intercede more early than we might otherwise. Signs of inflammation, high elevated C-reactive protein, high transferrin levels, interferon alpha, and IL-18 have all been at least talked about with small studies or discussions as possibly being. We don't have a very confirmed best marker though at this point, to my knowledge. Maybe Dave can teach us more in that regard. Okay, we've talked, Dr. Fiorentino, this is not one of those slides I'm just going to jump over because you did a great job earlier updating us on that. Again, most of us don't have to worry about the management in the ICU of these patients. There's a really nice review on this subject with a nice treatment algorithm. If you're interested, that gives you the current thinking in terms of the best approaches to treating these patients. The risk of a malignancy, certainly in adult onset disease, it can occur in juvenile onset, but much less commonly. And the clinically amyopathic subtype has a lower risk for associated internal malignancy. Originally, people thought it was probably the same risk, but there's been enough experience now that I think it's pretty clear that I still do the malignancy workup in them, but it's rare to find cancer in that subpopulation, in my experience. New serologic markers for this TIF1 gamma antibody, which is probably the one that people use most in terms of increasing their concern about internal malignancy. This is getting to be a complex area. There are a number of different antibody specificities now associated with myositis. Just to bring your attention down to this skin area that overlaps with lung disease. That's the MDA5 antibody. Overlap of malignancy, TIF1 gamma, calcinosis, and MPX2. This is a little dated, 2016, but they're clearly defining subgroups of both, not just amyopathic dermatomyositis, but classic dermatomyositis with these particular serologic markers. Cancer screening. Boy, that's been all over. What do you do? What don't you do? What's cost effective for internal malignancy workup for dermatomyositis patient? The two communities of rheumatology, American College of Rheumatology, the EULAR group in Europe, have come together and have included some dermatologists in formulating official guidelines in this regard. And I've circled in red here the dermatologists that were involved in this process. We've talked about IVIG. That's the rescue therapy for the patients that we see, but hopefully we can come up with something better than that in the future. And I think we're at the end because this is all pretty much about stuff that's already been discussed. So I would say to the young people here, if you in clinic see a patient, nowadays you just whip out your phone and you go to Google Scholar, you go to PubMed, and you can find stuff out real quickly. But if you can't find that patient with an extensive search, then you might have a new disease, and you could maybe put your name on that or come up with a novel name. That's how progress goes. I would say that the concept, particularly of amyopathic dermatomyositis, has been very important for human lives over the last 10 to 15 years, the concepts of these associations. And so don't be bashful there. I'll end with a few quotes. The master said, if names are not correct, language is not in accordance with the truth of things. If language is not in accordance with the truth of things, affairs cannot be carried out to success. We should not be ashamed to name what God has not been ashamed to create. So thank you for your attention.
We have time for a few questions for Dr. Sontheimer.
And I would just say thank you, Tony, for organizing the meeting. It's a very nice meeting. Thanks to the sponsors as well for making these meetings still possible.
Thank you. We're flattered to have you here, Rick. Any questions for Dr. Sontheimer?
Actually, I was going to, Christine Warren from the Cleveland Clinic. I was going to ask a question about a patient that Dr. Chatterjee, my colleague here in rheumatology, and I share, a woman with a myopathic dermatomyositis who first saw Dr. Chatterjee and was diagnosed, had been well controlled on hydroxychloroquine. And then suddenly she came in with a rash very different, to see me, very different than what she presented with originally. Originally, she had more of the classic rash seen in dermatomyositis, photo distributed. And then she came in and saw me with more of a lichenoid pattern and a photoprotected area on her trunk. Very, I think, red and violaceous initially, and then became more hyperpigmented. And our question, because I did find some case reports of a lichenoid appearing dermatomyositis, is have you seen patients with one morphology presentation of dermatomyositis that then later on flares with a different skin morphology? Or do you think this could be something, and what we were thinking about is a lichenoid drug reaction to hydroxychloroquine?
Right. No, I would be thinking along the same lines. The funny skin rashes that come up in dermatomyositis patients, in my experience, have been mostly it's a hydroxychloroquine story, and I suspect chloroquine could do that. And there's an antibody, one of the myositis antibody has some clinical correlation, the SAE1 antibody, that tendency to have lichenoid kind of inflammation flaring up after you start antimalarials. No, I can't say that I've seen that sequence. There are variant forms. There's just variant forms of dermatomyositis that can not be in the hallmark category. The list is actually quite long of the non-hallmark changes of dermatomyositis in the skin. But I don't think but I wouldn't be surprised. And that would be a scenario I would think about because I use hydroxychloroquine a lot in my early therapy of dermatomyositis. I always thought it had a steroid sparing benefit. When you're bombing away with topical, class 1 topical steroids are not getting better, start hydroxychloroquine, they melt away, So, and fortunately, we've not seen that same rate of adverse reaction to hydroxychloroquine in our patients at the University of Utah. That was reported by some of the other members of our department not too long ago. So why that varies, I don't know. One thought that we had about that was, well, maybe it's the water. And all Rocky Mountain water's got all kind of minerals in it and things, and East Coast water, where Boston is, where the reports of the adverse reactions have come mostly from these. We don't know, but it's certainly, that's a reasonable way to think about it. I don't know how else I would explain it.
Because initially when we biopsied it, the dermatopathologist said, oh, this would be consistent with dermatomyositis. And then I kind of went back and said, well, this is the history. Do you think there's any chance this is more of a lichenoid? And they said, well, yes, it could be consistent with that. So right now we're holding the hydroxychloroquine and we'll see what happens because we're coordinating care.
Well, her oncologist didn't slip in a little hydroxyurea, did they? Did she?
No, she has thankfully no malignancy that we are aware of. All right, thank you.
Yeah.
Rick, in patients, you mentioned about 80% of patients with SCLE have anti-Rho SSA autoantibodies. Does it mean anything to you clinically or in terms of the pathogenesis of SCLE if you order that and it's negative?
Yeah. Well, the early concept of that association with the skin changes and Rho antibody was another controversial area. It was mostly Dave Norris's work at that time, suggesting that the antibody actually created the damage at the dermal epidermal junction through antibody-dependent cell-mediated cytotoxicity, because we didn't see, there were a lot of T cells along the interface, and so they have to be involved or have some reason to be there. So that put together the Rho antibody humoral component with T cells, but that turned out not to be the case. It's antibodies are associated indirectly because what drives the plasmacytoid dendritic cells through the TLR receptors is immune complexes, including RNA or DNA. But antibodies are part of that mix that seems to really start the interferon process, getting it going in the skin.
Last question. What are your thoughts about Rowell syndrome? You think it's real? You think it's a unique entity, or you think it's just rip-roaring SCLE?
Well, I think Dr. I actually met him through Jim Gilliam. They were good friends and got a chance to meet him actually in my fellowship years. A very nice man. He didn't have a serologic marker. That was his problem. It was, he just had this description. These EM-like lesions occurring. Certainly, we have seen patients that meet all the other criteria for SCLE present with individual small lesions that look like targets. But you bring them back 6 weeks later and there are these annular papulosquamous changes. But early on, I could see where there might be a period you'd see some patients with a lot of targetoid-like lesions occurring in that context. And they had the right antibody, but they had, it was a Sjogren syndrome antibody, and so they didn't link together with lupus in those days.
Great. Rick, thank you very much for a great talk. It's a pleasure to welcome our next speaker back to the podium, Dr. Michelle Kallenberg. I'm not going to go over her entire bio. She's a rheumatologist and a prominent researcher at the University of Michigan. She alluded earlier that she would be giving this talk, so we're going to shift from past, present, future to present and future, and she's going to give us a presentation on the present and future insights into the pathogenesis of cutaneous lupus erythematosus.
All right. Thank you very much. I'm back. So, and thanks for that great talk as well. I think helpful to set the context actually here. Again, my disclosures, and there's some more references in the slides if you're interested. So when we think about pathogenesis, in autoimmune disease in general, I think there's several factors at play. One is a genetic predisposition, and we've heard about some of the HLAs and things that predispose people to get autoimmunity. So you have this genetic predisposition, but something has to act on those genes, right? And so we think about environmental triggers as an important driver that then cause innate immune activation, which then educates our adaptive immune system to, cause autoreactive T cells and then activate autoreactive B cells, and you get antibodies and immune complex formation, and you can kind of have this cycle keep amplifying until you have clinically evident disease. And so in cutaneous lupus, we kind of talked about earlier that there's, many different types of cutaneous disease, but one of the factors that really is a unifying feature is photosensitivity. And this is probably a really important environmental trigger for both cutaneous lupus and systemic lupus patients. And if we think about just over the past 20 years, our understanding of the pathogenesis has really evolved a lot. This is from a recent review article where they just were kind of highlighting both the immune system and the skin. And I think if there's one take-home message that you leave here with is that cutaneous lupus is not just about the immune cells. It's about the skin itself being dysfunctional and contributing to the inflammation. So if you're tired and you had a nice lunch and you want to take a nap, if you remember that, you'll walk away with the highlights of the talk. So when we think about cutaneous lupus itself, we really think about interface dermatitis as the classic pathologic feature. And when I look at, past discussions about cutaneous lupus, there was really a lot of focus on the interface change. And, if you look back at, I've read some old reviews from like the early 2000s, just looking at what people were saying at that time. And it was really, this looks like an antiviral response in the skin. You see a lot of MX1 upregulation. This looks antiviral. And really then it became known that these type 1 interferons were being produced in the skin. And if you have an interferon response, it can cause an interface change. The other thing that was noted when people were studying the biopsies of cutaneous lupus was that they could find cytotoxic T cells. So this is a CD3 stain here on this panel. And then they could see, upregulation of like granzyme and other things. So they said, oh, there's cytotoxic T cells here. They must be killing off the keratinocytes at this interface. And that's what's driving disease. And you could see keratinocyte apoptosis that was present at this interface. And so that was sort of thought to be the underlying pathogenesis of cutaneous lupus in the 2000s. So, and like I said before, the immune system has classically been the focus of study in lupus, but I'm going to challenge that a little bit with this talk. Not that the immune system is not important, but it's not the only piece. And one of the things that I'll just put out there is food for thought, because I'm not going to talk about T cells the rest of this talk, is that the role of T cells in cutaneous lupus really isn't clear. So this was a study we did with Deepak Rao where we took our single-cell RNA sequencing data from 7 cutaneous lupus lesions. It included both SCLE and discoid lesions. And we compared that to biopsies done through the AMP of kidneys of patients with lupus. And here we're just looking at the number of T cells in lupus nephritis, which is red, and in cutaneous lupus, which is blue. And you can see here that the cytotoxic T cells, the CD8 positive cytotoxic T cells, are much higher in lupus nephritis than what we see in the skin. Okay, well, fair. So we included SCLE lesions in this. They don't have as much inflammation. Maybe that's why. But if you actually look in this figure here, what we did was we looked at activation signatures across the different T cell compartments. And you can also see that the cytotoxic CD8 T cells are less activated in cutaneous lupus than in lupus nephritis, suggesting that the T cells themselves might not be as important in the skin as they are in the kidney. And you can see here in this figure, when we do a cross-transcriptome comparison of all the cytotoxic T cell markers, you can see in lupus nephritis, it's really robust. And in cutaneous lupus, it almost looks like healthy control. So even though we can see these cells in the skin by staining, when we look at single cell data, it doesn't really support a really robust active T cell pathogenesis of cutaneous lupus. And in my brain, this is one of the reasons why I think our DMARD therapies don't always work for patients, right? So we have patients who fail methotrexate and who fail CellCept, despite their nephritis coming under control on CellCept. And I think it's because the T cells just aren't what's driving the disease. So I'm not going to talk about T cells anymore, but I think this is really kind of a shift in our thinking over the last 5 years or so as we've learned more about the T cells in CLE. And so, excuse me, one of the focuses of my lab has really been looking at the skin itself and how this could be contributing to disease. And so if we just, look in the literature for what people have described as drivers of cutaneous lupus pathology, mouse models are one way for us to understand disease. And I fully understand the caveat that there's no great mouse model of cutaneous lupus. But there have been models that have shown us that models like Anne Marshak-Rostein's, where you have this antigen-specific killing of keratinocytes that is triggered by these ova-specific T cells that you transfer into irradiated mice. And one of the things that they showed was that this ability to get these CLE-like lesions, you can see here on the mouse, is really dependent on the type 1 interferon receptor. And they could show that the mice got a bunch of PDCs, but if you blocked the interferon receptor, you don't have PDC infiltration into the skin lesions of this mice. There's also other models here. They knocked out PD-1H, which is an inhibitory receptor on T cells, or an inhibitory ligand expressed on myeloid cells. It's also called VISTA. And these mice can get a discoid-like lesion. And I say discoid-like because there's really not a lot of interface change here. But in about a third of the mice, and they also see this high interferon signature and a more robust response to TLR signals. And they also were able to see increased PDCs and neutrophils in the skin prior to lesion development. So the normal skin was inflamed even when it didn't have a lesion, which is another theme of lupus that I will come back to. And then in other models, so there was this older model which showed that if you oxidize DNA with UV light in culture and inject that into the skin of mice, you can trigger cutaneous lupus-like reactions, especially in a autoimmune prone background. So you can see here all the inflammatory infiltration that you get by injecting this DNA. And then also, which I think is interesting, this other group made a mouse that was deficient in the enzyme that repairs oxidized DNA damage. So this 8-hydroxyguanosine adducts that form on DNA, if you get rid of the enzyme that replaces them, these mice get alopecia. And they also were reported to have cutaneous immune complexes and epidermal hyperplasia. The histology for this paper was really hard to see, and it was not very robust. So I don't think this is cutaneous lupus, but they definitely lose their hair. So they're getting an interesting phenotype, and they also had a high increased interferon signature in the skin. So all of these mouse models of cutaneous lupus are really pointing to type 1 interferons as being important in driving the disease. And as I talked about in my first talk, we also know that cutaneous biopsies from lupus lesions, type 1 interferons really are ubiquitous across the spectrum, whether you have CLE only or CLE plus SLE, and no matter what lesion subtype you look at. One of the interesting things, if we think about interferons as possibly be important in driving disease, is that Ed Vitale showed in this paper in Nature Communications a couple years ago that if you have a positive ANA and not a defined autoimmune disease, so he calls them at-risk patients, some people would call it an incomplete lupus patient, but these patients actually have a cutaneous interferon signature. So you can see here that this is lupus patients. You can see in the blood, you can see a little bit of an interferon signature. In the skin, it's like lightning years ahead of what you can find in the blood. So the skin is a much better biomarker for the interferons than the blood is. But even in these at-risk patients, you can see that you get this pretty robust interferon signature. Now you can see the scale is much different, right? It's not as big as what you see in full-blown SLE patients, but you can still see an interferon signature in these at-risk patients. And we've done a lot of work in our lab over the last 10 years describing some of the important things that interferons are doing in non-lesional lupus skin. And I want to emphasize this interferon signature is in the non-lesional skin. We typically study the buttock area that's non-sun exposed in these patients, and you still see that interferon signature there. But we know interferons are important for activating dendritic cells, that they increase cytokine production like IL-6. They also are promoting disruption of the skin barrier and probably facilitating colonization of lupus patients by Staph aureus. Teresa Liu at HSS has also shown that they're probably important for helping to deplete Langerhans cells, which have a protective effect on keratinocytes in lupus skin. And we also have shown that the interferons are actually really important for inhibiting Treg function and promoting T cell activation after exposures like UV. So in a high interferon environment, the skin's behaving very differently than it does when the interferons are not there. And so one of the main questions that we've been focused on in the last few years is where does the interferon in the skin of lupus patients actually come from? And you've heard about plasmacytoid dendritic cells being discussed, and they've pretty much been considered important interferon producers in the skin of cutaneous lupus patients. I'm going to blow your mind, but there really is no evidence that they actually make interferons in the skin of lupus patients. So almost all of the PDC studies have been done from PDCs isolated from normal healthy controls. So what we do know about PDCs in the skin is that PDCs are known to express a protein called BDCA2, and you can stain for interferon-related genes and for BDCA2, and you can see that there are some immune cells that are positive for BDCA2 in the skin of lupus lesions. And these were taken not from a litifilimab study, which is the phase 3 drug for CLE plus minus SLE, that's the anti-BDCA2, but this was a different compound that was targeting BDCA2. But here you can see that you can deplete these BDCA2 cells from the skin, and you also lose this MXA staining. So by giving the antibody against BDCA2, you can deplete MXA or get rid of the interferon signature in the skin. So that's our human evidence that these PDCs are important. However, other people have shown that the PDCs from lupus patients are relatively inert. So this is from Ed Vitel's study where he looked at PDCs isolated from lupus patients and healthy controls. And you can see the PDCs are already at-risk patients and in lupus, you see fewer PDCs in circulation just by flow cytometry. And then if you hit them with a TLR agonist, you can see that you can get, this is staining for interferon alpha by flow, you can see you get very nice upregulation either with TLR9 or TLR7 stimulation of interferon production in healthy controls. And in lupus patients, they don't make any. So PDCs isolated from lupus patients, you can't make them make interferon. And he had another very nice paper that came out around the same time in Journal of Immunology where he showed that TNF alpha exposure, and here he's doing a dose response, if you hit PDCs with TNF alpha and then try to turn on interferon production, it doesn't work. So TNF alpha is inhibiting PDCs from being able to produce interferon in the skin. The other piece of data that I think is kind of compelling is that Vicki Wirth has published tissue mass cytometry data in cutaneous lupus lesions where she has looked at interferon beta positivity and looked to see what cells actually are expressing interferon beta in cutaneous lupus lesions, and it's not the PDCs. So it does not overlap with any PDC marker, and instead it overlaps in the myeloid cell populations. So we have data that by staining, they're not making interferon, and in circulation, they're not making interferon, or we can't make them make interferon. So what is the role of PDCs then, and why would these drugs that target BDCA2 actually be beneficial? Because so far the data has been pretty good that you can get some effects in lupus with these drugs. And all the mouse models, if you deplete PDCs, it fixes every mouse model of lupus. So maybe these PDCs make interferon when they first hit the skin, but they get TNF exposed as part of the inflammatory milieu, and that turns them into a more pro-inflammatory antigen presenting phenotype, maybe. Maybe they're just not important for making interferon in lupus, maybe. Maybe these PDCs get really prone to death by this interferon exposure, and I'll tell you by our single-cell RNA sequencing data, we've sequenced, 14 paired non-lesional patients now, and I think in only 2 patients in non-lesional skin, we were able to find PDCs. Nobody else had any PDCs that we could find by single cell. And we've done post-UV single cell RNA sequencing, and again, we don't see any PDCs at a 24-hour time point coming into the skin. So maybe they don't survive single cell RNA sequencing, I don't know. Maybe they're just dying rapidly, but who knows? And then the other thing that I think is kind of compelling and interesting is that all of our data about PDCs in the skin have been based on staining for things like BDCA2. But it's known that myeloid cells can actually turn on BDCA2 in inflammatory environments. So what we're calling a PDC by immunohistochemistry, maybe it's not a PDC. So I think there really needs to be a lot more work done with like multiple stainings, really trying to characterize what these cell populations are. Now, the truth of the matter is maybe these BDCA2 drugs are going to work great, and who cares? Like, we're just, moving deck chairs. But I still think it's important just to know like what exactly we're targeting, because there might be better ways to target it than BDCA2 antibodies. So I think that's kind of an evolving piece of the puzzle for cutaneous lupus. And then I think, there's other sources of interferons. So both non-lesional and lesional skin have a really strong interferon signature. I think I've mentioned that a few times now, but this is from our single-cell RNA sequencing paper we published in Science Translational Medicine a few years ago, headed by Allison Billy, a brilliant dermatologist at University of Michigan, if you haven't met her. And one of the things that we found was that in lupus patients, there's really a unique population of basal inflammatory keratinocytes that we isolate from non-lesional and lesional skin in these patients. And you can see here that if we apply, this is supposed to say interferon alpha, there must be a box here or something. But if we look at the type 1 interferon score, these inflammatory basal keratinocytes that are really lupus specific, you can see here there's really no healthy controls in this population, really have a robust interferon score as well as a TNF score. And if we compare non-lesional to lesional skin, you can see that the interferon alpha score is actually higher in the non-lesional than in the lesional keratinocytes. So in these non-lesional biopsies, again, are taken from the upper thigh and non-sun exposed, non-lesional areas. So really, this is sort of like a global phenomenon in these patients where they have a lot of interferon at baseline. And we had done studies, a while ago now, just looking at the interferons that are expressed in cutaneous lupus lesions. And this was done by microarray. And we were so interferon beta was not able to be picked up on this array. So take that for what it's worth. But one of the things we did find was that interferon kappa seemed to be really robustly increased in cutaneous lupus lesions. And only interferon alpha 10 really had any other increase. So this interferon kappa actually seemed to be kind of a unique feature of cutaneous lupus. And we published another paper that showed that it's also increased in dermato. And keratinocytes are known to make a lot of inflammatory cytokines. This is from a review I wrote with Johanka Johnson, where we just kind of did RNA sequencing, treating keratinocytes with all sorts of different stuff and looking at what they make. And you can really see keratinocytes are good at making a lot of stuff. And it turns out that they make interferon. So they make a lot of interferon kappa at baseline. These are from cell keratinocyte lines that we grew out of primary biopsies and just cultured the primary keratinocytes. And you can see that healthy control keratinocytes, and this is about at passage 3 where we did this Western blot, you can see there's some baseline interferon kappa being produced, but in lupus it's much higher, and this correlates with an increase in STAT1 and STAT2 activation, suggesting that the interferon receptor is being chronically activated by this interferon kappa loop. And when we treat with TLR ligands like peptidoglycan or with UV light, we can see an increase in interferon kappa protein production, much higher in lupus versus healthy control keratinocytes. And Ed Vitale had published an RNA scope of just treating lupus patients with UV, and you could also see increased interferon kappa production in the keratinocytes of these patients as well. So we think interferon kappa is an important type 1 interferon that's contributing to this signature chronically in lupus skin. And Vicki Wirth also published that it might not be a keratinocyte-specific interferon. So this was another tissue cytoph paper that she put out where she looked at interferon kappa staining in lupus lesions, and she showed that this was in the keratinocytes, but also in myeloid cells. She was calling them CD16 positive macrophages. We think they're probably CD16 positive dendritic cells based on our single cell data. I think we're describing the same cell population. It's a little bit hard to know exactly what the cell type is, but we think we're probably studying the same thing. But one of the things that you can see is that there's a ton of co-staining of phosphorylated sting, which is an important upstream activator, which I'm going to talk about later, in the cells that are co-staining for interferon kappa. So the ones that are making kappa are being activated for sting as well. So we've got all this interferon being made by keratinocytes, probably myeloid cells, maybe PDCs. But the other thing that's really interesting about the skin of lupus patients is you really see this shift in crosstalk between the stromal cells, and I lump epithelial cells in the stroma just for vocabulary ease. But what we see is that in healthy controls, so on the y-axis here is all the different cells that would be making communication devices in the cell. So these are chemokines and cytokines and other things that these cells are making. And then on the bottom are the ones that have receptors to those particular chemokines and cytokines and other things that these cells are making. So you can see in healthy control skin, there's like this homeostatic crosstalk. Keratinocytes are talking to keratinocytes, kind of maintaining the skin. Fibroblasts are also talking to keratinocytes. And there's a little bit of T cell crosstalk going on kind of across the board. And then the melanocytes and the myeloid cells are just kind of quietly doing their thing. What we see in non-lesional lupus skin, looking at this receptor ligand crosstalk, is that now we actually are getting a lot of crosstalk of keratinocytes to endothelial cells. We're getting fibroblast crosstalk to myeloid cells. And then we're getting myeloid cells talking to keratinocytes and fibroblasts and other myeloid cells and endothelial cells. So you're seeing even in non-lesional skin the shift where you're getting a lot more crosstalk with inflammatory cells. And then in lesional skin, there's a lot more chatter going on with the inflammatory cell populations. And one of the reasons I bring this up is because I think another important shift in our thinking about pathology is that it's not just even the keratinocytes that are important, but we're also seeing shifts in other cell populations. And this is just to highlight that in lupus lesions and non-lesional skin, we see a robust population of interferon-educated fibroblasts as well. And these fibroblasts are regulated by the top upstream regulators are predicted to be like interferon alpha, interferon beta, interferon gamma, and as well as interferon lambda. So they all kind of signal the same way, so it's a little hard to parse out which one's the most important. The other thing that's important there is that TNF is also signaling in these fibroblasts. So we're getting a lot of interferon education, even in the non-lesional skin of these lupus patients. And we just had this paper come out earlier this year where we showed that one of the interesting things is that if you look at the response to TGF-beta by these fibroblasts, in the fibroblasts that we isolate and grow from patients who have scarring skin disease, they actually have a switch in their response to TGF-beta. So instead of making kind of more inflammatory wound healing type program, what they actually do is upregulate collagens. And so we think it's this interferon education in the skin, and thinking about, why discoid patients develop scar, when you actually have patients with scarring skin disease, they seem to have a shift in how they respond to TGF-beta. So we think that maybe some of this in vivo education is important in that shift in how these cells respond to that particular cytokine. So the fibroblasts are there, and then I mentioned, we also see this population of CD16 positive dendritic cells that are really prominent in cross-talking both with the interferon-educated fibroblasts, as well as some of the other cells, maybe plasmacytoid dendritic cell-like, et cetera. And one of the other things that we've been able to parse out through our single-cell work is that these cells look very different when they're in the skin versus when they're in the blood. So if we use a feature called pseudotime where we can basically look at the transcriptional profile of these cells when they're in the blood and in the skin, and then map out all of the transcriptional changes that happen as these cells migrate through into the tissue. And one of the things that we find is that they really get educated by interferons, TNF, and IL-1 when they enter into the skin. And so they're behaving very differently in the tissue than they are in the blood. So I think the first part of the summary of our pathogenesis evolution is that I think T cells are probably less cytotoxic in the skin than we expected. Keratinocytes and myeloid cells and maybe PDCs are making a lot of interferon in the skin, even in non-lesional skin. And this interferon generates a pro-inflammatory environment that is miseducating infiltrating cell populations. And we think even non-lesional keratinocytes are really participating in this. And so again, I talked about this morning, sunscreen is so important because they're ready to misbehave with any trigger. And then these skin resident cells like the fibroblasts are also being differentially activated by these interferon signals and causing them to change their behavior. So instead of wound healing, maybe they're forming scar. So as the second part of my talk, I want to kind of come back to this environmental trigger piece and talk a little bit about some of the photosensitivity work that we have been doing. So I think this is important. So we published, gosh, it's been 6 years now, that we think interferons are really important in promoting a photosensitive phenotype. So if we just look at cell death in culture, this is comparing healthy control keratinocytes isolated from the upper thigh or lupus non-lesional keratinocytes isolated from the upper thigh and grown in culture, and we just expose them to a low dose of UV. So this is 50 millijoules per centimeter squared, which is about a 30-minute Michigan sun exposure. You can see that you get a really increased rate of cell death as we measure by tunnel positivity in the lupus keratinocytes compared to healthy control. And we can mimic this by generating a keratinocyte cell line that overexpresses interferon kappa about twofold, which is about what we see in lupus skin. Cells won't survive if you try to drive the interferon expression up anymore. They just stop dividing. But you can see that we can replicate this increase in cell death just by overexpressing interferon kappa in these cells. And one of the interesting studies that we did was we took our control and healthy control in lupus keratinocytes and added baricitinib into the culture. So this blocks JAK1, is blocking interferon signaling. We don't add any interferon in, it's just blocking that increased interferon signaling that gets turned on. And then we hit them with UV. And what we saw was that the cell death rate in lupus cells goes down to about what we would expect in normal. And interestingly, in healthy controls, it goes to like 0. They just don't die with baricitinib, which if you think about skin cancer risk and JAK inhibitors, this is really interesting, right? Like we can prevent their apoptosis, probably preserving mutations. But in lupus, they still die. They just kind of go back to normal. So we actually just finished a study with the assistance of the NIH, with our clinical autoimmune center of excellence at University of Michigan, where we did a trial of tofacitinib. We phototested patients before and after tofacitinib, looking at cell death rates. So we're in the tunnel staining is being done today. So we're going to have data to show whether JAK inhibitors are actually changing some of this abnormal photoresponse in patients. So stay tuned for that. But we know that it's not just any type of cell death. We just published a paper in Frontiers in Immunology where Shannon Loftus, my graduate student, now Dr. Loftus, she hammered on all the different cell pathways that interferon might be changing in order to promote cell death. And it's really an apoptosis phenotype. So she looked at every other pathway you can think of. The reviewers even made us go back and study for apoptosis. And what we saw was that really it's a caspase 8 dependent, IRF1 dependent increase in apoptosis when we have priming with interferon prior to UV exposure. So this is really promoting that form of cell death. And the other thing that we saw was that you could actually shift the dose response of cell death just by giving interferons first. And so we can start to see a significant increase in cell death with only 20 millijoules of UV. If you prime with interferon first, whereas without the interferon priming, you don't really start to see cell death until you hit about 50 millijoules per centimeter squared. So again, the interferons also seem to shift that dose response for how much UV light you need in order to have an effect. So we know lupus skin has a lot of interferons at baseline. So we wanted to look at whether interferons were actually changing how UV light was interacting with lupus skin. And so one of the things that we did was we had these photo testing experiments that we had done. And so we just looked at the activation of sting in lupus skin. So in healthy controls, you can see without any UV exposure, there really is no sting activation at baseline. And again, this is measured by phosphosting. Sting gets phosphorylated when it's activated. And with UV, you can see that sting phosphorylation goes up in healthy control skin. You see it primarily in the basal keratinocytes. But one of the observations we had that was very interesting was that with no UV at all, and this is again from non-lesional, non-sun exposed skin, we see this increase in phosphosting staining in lupus patient skin in the basal keratinocytes, again, with no UV. And then when we UV them, this goes bonkers. It goes up a lot. So we see this increase in phosphosting activation at baseline in lupus patient skin. And so we wanted to see whether there was sting-specific drivers that could be doing this. So this work is all done by Ben Klein, who's a fantastic dermatologist from Leipzig, Germany, who's been doing a postdoc with me in my lab. He's amazing. Give him a job if you're looking. But one of the things that we started out asking, because it's known that UV light induces mitochondrial reactive oxygen species, and so whether we needed this reactive oxygen species formation in order to drive interferon production in response to UV exposure. So we used a couple tricks. One is a drug called Mitotempo, which specifically reduces mitochondrial oxidized species. So Mitotempo prevents mitochondrial oxidation. And then we have this MitoSox, which stains for oxidized mitochondria. So you can see with UV, you get a lot of MitoSox staining, suggesting that reactive oxygen species are going up in the mitochondria. You notice you don't see it in the nucleus, right? It's all in this perinuclear mitochondrial area. And with Mitotempo, you can block this reactive oxygen species upregulation with UV exposure. This is just graphed out here. It looks pretty nice. And what we saw was that with Mitotempo, you don't get upregulation of interferons. So this is looking at interferon beta. And I will say interferon beta is a very quick responder to UV. You see it go up within 4 hours. Interferon kappa takes longer. We've published a paper on it. I won't get into the story now, but interferon kappa seems to behave more like a downstream regulated interferon gene. But regardless, Mitotempo is able to block interferon upregulation as well as interferon lambda 3 upregulation, and then the downstream interferon genes like interferon kappa as well as MX1 OASL. So if you block mitochondrial oxidation by UV, you don't get the interferon response. Which somebody asked me about this drug called Helioplex or Helio something. Where are you here? Yeah, HelioCare. So I looked it up. It's an antioxidant. So if it works, which I don't know if it does, but if it works, this might be why, because it could be blocking the reactive oxygen species upregulation after UV light. So if I had to pick a mechanism as to why it works, that's probably why. But again, I don't know if it works. I have no experience with it, but you tell me you like it. So, okay. So we knew that interferons go up. It's mitochondrial dependent. Oh, the other thing I'll put out there, going back to my first talk where we talked about it doesn't matter your skin color, you need to wear sunscreen as a lupus patient. So melanin is a perinuclear protector, right? So it protects your nuclear DNA. It does not protect your mitochondrial DNA. So if all of the activity is going on in the mitochondria after UV, it doesn't matter what your skin color is if you have lupus, because if all of this stuff is coming from the mitochondria, you're not going to be protected no matter how much melanin you have. So that's another, I think, interesting and important take-home point. So we think that something's happening in the mitochondria. So one of the things we know is that mitochondrial stress leads to the release of mitochondrial DNA. And one of the things that mitochondrial DNA does is it takes on a Z conformation. And so before I put everybody to sleep talking about DNA conformations, the way that, so Watson and Crick, the B DNA is the normal double helix conformation, right? So what happens when something is in Z DNA, it flips opposite. And it's very unstable in that conformation. It doesn't like to do that. But things that make it more likely to make Z DNA, 1, oxidation, 2, GC-rich areas, which the mitochondria is full of. So mitochondrial DNA has a propensity to flip into the Z conformation. Now, it normally won't stay there. It'll flip back to the B conformation. However, there was this paper that came out in Cell last year, which showed that there's a protein called ZBP1, stands for zDNA binding protein 1, which is able to bind to Z conformation DNA and stabilize it in that conformation. And what this paper showed was that ZBP1 could bind to C-gas and bring this zDNA in contact with C-gas and C-gas then makes cyclic GMP, which activates STING. So it's thought that this zDNA is a really good way to activate STING if you have ZBP1 to act as a bridge. So we were curious whether this was happening after UV and whether interferons could influence this zDNA formation. So I know it's probably hard for you guys to see on these screens, but the gist of this is if we look at UV treatment, and we have little white arrows here highlighting the zDNA staining so you can see it better. But if we treat with UV, you can see there's a little bit of zDNA. This purple staining is TOM20, which is a mitochondrial marker. So you can see we get this zDNA coming up outside of the mitochondrial network, suggesting that this DNA is being released from the mitochondria. If we use Mitotempo to protect against that oxidation response, we don't ever see any zDNA. If we just give interferon and not UV, again, we don't see any zDNA. But if we give interferon and then we hit with UV, we see a lot of zDNA coming out in these cells outside of the mitochondrial network. And again, this is blocked by mitotempo. So it seems like UV can induce this and interferon enhances it. So one of our thoughts was, well, maybe there's a lot more ZBP1 in lupus. And it turns out ZBP1 has been reported as an interferon-sensitive gene. And so we looked in our databases of all the photosensitive diseases we had access to. So cutaneous lupus, both discoid and SCLE, have high levels of ZBP1 expression. Doesn't matter if you have systemic disease or not, you still have a lot of ZBP1, and it correlates very nicely with the interferon signature in the skin. Same for childhood onset SLE. We have fewer skin biopsies from these patients, but they have increased ZBP1. Same for adult dermatomyositis and juvenile dermatomyositis. Everybody has high ZBP1 in the skin. And so we stained with protein to confirm, because gene signatures aren't always reflective of protein, but you can see ZBP1 is high in discoid, SCLE, and adult dermatomyositis skin. And if we hit with UV and do this staining again, and I didn't show you all the staining, just the quantification here, but we again see a higher ZBP1 after UV exposure as well, suggesting that this gets turned on even more by UV. And so then we thought, well, okay, so ZBP1's high. Do we actually see more zDNA in lupus keratinocytes? And so again, here's the lupus keratinocytes here. We actually see a little bit of baseline zDNA in these lupus keratinocytes, and then with UV, it goes way up. So it's quantified over here. So you can see, in controls, we get a little bit with UV. If we prime with interferon, we get a lot. In lupus, there's a little bit at baseline. We don't have to prime with interferon in the lupus keratinocytes. They just make a ton of zDNA after UV exposure. And we can see that this zDNA is co-localizing with CGAS. So here's just priming with interferon and then staining for zDNA and CGAS together. And you can see we get these big specks of co-localization, suggesting that there's these complexes coming together that are activating STING. And we showed that the zDNA is really STING dependent. So when we transfect in, whoops, I don't know how to go backwards. There we go. So if we transfect in either B conformation DNA or Z conformation DNA, you can see zDNA at the same concentration is much more robust at turning on CGAS and STING and activating interferon signaling. But in the absence of STING, we don't get any interferon production at all. And so we then made knockout lines where we used shRNA to knock down ZBP1. And you can see that with UV or interferon priming, we really don't get as much interferon produced if we prevent ZBP1 from being turned on. And then we made a cell line that overexpresses ZBP1 to see if that could be sufficient itself to drive interferon production. And sure enough, our ZBP1 overexpressor cell lines really spontaneously produce all the things that we see in lupus, all the interferon regulated genes, interferon beta, interferon lambda. So really this seems to be sufficient. And I didn't put the slide in here, but we also see spontaneous activation of CGAS. It's normally sequestered in the nucleus to keep it off, but in these overexpressor lines, we see CGAS really cytoplasmic pretty much in every cell, suggesting that this really is driving CGAS activation. So we think in photosensitive diseases that really there is this predisposition by interferons to upregulate ZBP1, so that if you have an oxidizing stimulus hit the cell, like UV, it's ready to capture any Z conformation mitochondrial DNA that gets released, and it links it to CGAS and turns on STING, which then activates type 1 interferons downstream. We don't think that the interferons themselves are promoting the mitochondrial redox state so much. It's really in driving the capture of any of these oxidized Z conformation mitochondrial species that are being released from the cell. So I think, looking forward, I think one of the interesting things we have now to study is we have the ability to block interferons in lupus patients. And so how does this affect their photosensitive responses, and is this going to change photosensitivity in patients? I do anecdotally have patients who tell me that they feel like their photosensitivity is better on anifrolumab. And then again, we just finished this phase 1 proof of concept trial using tofacitinib to block interferon signaling. And so we'll actually have some data from those patients. We had 6 patients go through that study. And then again, there's other drugs coming down the pipeline, as I talked about before, that can either inhibit PDC function, which may also interrupt this chronic interferon cycle, or targeting things like TYK2, which is on the interferon receptor, which also would interrupt the interferon cycle. So this may also be of interest in this regard, but we, I think, still need more research. And I think studying patients who are on these drugs is going to be really beneficial in understanding how they're working. So the second part of my talk, the summary, is that mitochondrial dysfunction seems to be contributing to interferon production in lupus skin, and that ZBP1, I think, is a novel rheostat for tuning interferon production after UV exposure. And the cGAS STING pathways are also probably important targets for treatment of prevention of lupus lesions, and I know there's several companies, working in this space right now. So I think there's going to be more stuff coming down the pipeline to give us ways to treat these patients. So overall, things I want you to take away, I think cutaneous lupus lesions, they exhibit interface change. So that's where we anchored our pathology many moons ago. But it's really, I think, interferons, not T cells, that are drivers of cutaneous lupus lesions. And interrupting this interferon cycle benefits disease. And I think I showed you this morning many examples of patients who are, responding to interferon blockade. And the other thing that I told you was that the lesions come back when you stop the blockade. So blocking the interferons itself is not going to be what cures these patients. We have to get at the underlying drivers. And that's kind of where my research is going now is, okay, so we know that the mitochondrial dysfunctional, so why is that? So we're, continuing to work our way backwards to, the chicken and egg cycle, but figuring out sort of where things go wrong in the first place, I think will be important for really curing these patients long term. And then the other thing I want you to take away is that non-lesional skin is not healthy in lupus patients. It's really primed to hyper-respond to triggers like UV, and it has a lot of interferons present, and there's actually some inflammatory cells in that skin, even if it looks fine on the surface. And so really working with your patients and cautioning them to be careful about their exposures, I think, is important to keeping them healthy long term. So with that, I just want to thank my current lab members, my former lab members, the many, many collaborators that have contributed to our work and our funding sources, and of course the patients at the University of Michigan Lupus Program. We can't study a disease if patients don't give us something to study, and my patients are incredibly generous with skin biopsies, and we could not do any of this work without them. So I will be happy to take any questions.
Any questions for Dr. Kallenberg? You've shown us an amazing amount of incredible work. So, I think, to me, a few of the things that stand out is, traditionally, I think we are taught that the plasmacytoid dendritic cell is the key cell that's producing type 1 interferon. And you're showing us that it may not be, it's not for sure, but without question, there are many other cells in the skin that are producing type 1 interferons, including keratinocytes. So I think the other thing is we traditionally think of the skin as being a victim. A patient has lupus, it's beat up by lupus inflammation. And I think what I take away from this work is that it may be part of the problem. It's actively involved in creating lupus. Is that fair?
I think it's probably the Kool-Aid that I drink. I think it's always a little bit of a chicken and egg. I think one of the places that we're doing a lot of work now is really looking epigenetically at lupus skin to see how it looks different. So we published a paper last year showing that there's dysregulation of hippo signaling by an epigenetic mechanism in lupus keratinocytes, and that's contributing to this propensity for cell death. But we haven't yet figured out why the interferons are so prone to being high. I think there's lots of good ideas. We just got an R01 funded. The NOA came today with John LaCava and Tomas Mustelin at University of Washington to study these retro elements in lupus keratinocytes because we know that they can become leaky. Peggy Crow showed very nicely that you see increased line 1 production in Sjogren's syndrome patients and in lupus patients. And so whether that is enough to sort of like misprime the mitochondria to be more oxidized and to sort of, you know, shut off OXPHOS and turn on some of these other pathways, whether that's it, so it's de-repression of these line elements, or whether there's other epigenetic modifications we don't know. We have I'm waiting for my NOA to show up for this one, but we've got an R01 that should be getting funded that is going to look at multi-omic sequencing pre and post anifrolumab. So we're going to look at epigenetics and what happens when you block interferons. But I want to do it in patients who get at least 6 months. Because again, the patients who've responded and not tolerating come off, their rashes come back. So I'm curious if you leave them on long enough, if we can reset the epigenetic program in the keratinocytes to make them look more like healthy controls. So that's another approach that we're taking. I think also studying the incomplete lupus patient population is another place where there needs to be a lot of energy.
So that's a really interesting population because clinically they look normal. They may have a positive ANA and they have a type 1 interferon gene signature in the skin. What do you think that means in terms of developing systemic lupus? Do you think there's type 1 interferon expression, overexpression in the skin that makes patients prone to develop systemic lupus?
Yeah, so I have 2 ways to answer that. One, so we've got a replication of that experiment. We collaborated with a group in the Netherlands at Groningen. Svenja Henning came to my lab for 6 months and brought a whole pile of ILE biopsies with her. So we're doing spatial seq and RNA bulk seq on those. And we definitely see the interferon signature in those. And they have data on who progressed and who did not, because these are about 10-year-old biopsies. So far, we don't see with the progressors that the interferon signature seemed to make a difference, whether you stayed ILE or whether you progressed to have another disease. What we saw was that if patients had skin rash as their ILE qualifying criteria, their interferon signature was higher. So I think interferons are really good at pointing out who gets skin disease. And we also have data we're going to submit for abstract to ACR this year. But if we look in the non-lesional skin of lupus patients and look at those who have skin disease, which is about 70% of patients versus those who've never had skin, it's really only those who get skin disease where the interferon signature is high. So we don't see a really strong interferon signature in patients who never get skin disease. And all of this data that I showed was biopsy because we were always studying patients who got skin disease because we wanted to look at patients who got skin disease. But when we backtracked and kind of looked at, now we've collected a bunch of patients in our longitudinal core and we have that data, the interferon signature is really more of a skin related thing. But we also have this mouse model, which we're finishing up the paper right now, where we overexpressed interferon kappa in a black 6 background, so very wild typey mouse. They get splenomegaly, they get T-cell activation, they get myeloid cell activation just by driving a little bit of interferon in the skin of those mice. So, but they don't get full-blown lupus. So I think it's enough to get the immune system ready, and there's probably a second hit that needs to come in order to flip the switch all the way over into full-blown autoimmune organ damage.
The other interesting thing I think you've shown is that, you're as you mentioned, you're taking biopsies from non-sun exposed skin, like the buttocks, and there's a type 1 interferon signature. So, I mean, once a patient sort of activates that pathway, do you think it's just entire body surface area pretty much? And if so, how does that, what is your thoughts about how that occurs? Is it this education of these stromal cells that just sort of spreads?
Yeah, that's a good question. I mean, I think there's a couple of things, right? So I get this question not infrequently, and I think there's probably multiple things that can contribute in different patients. So one is, there are these immune complexes that sort of line up at the dermal-epidermal junction and could be having an effect. Now, when we grow the cells in culture, they maintain that interferon high phenotype despite, multiple passages. So I don't think it's something that's like driving the persistence, but maybe it's part of the trigger that gets things going. I think we know that there are inflammatory cells getting recruited into these non-lesional areas. And so whether they're participating in a crosstalk cycle where they make some interferon, and we know interferon begets interferon. The more interferon you're exposed to, the more interferon you'll make when you get a trigger. So it's kind of this feed-forward loop. We haven't looked very carefully at the off switches to see whether there's any particular dysfunction in lupus skin that forgets to turn off the inflammation. So I think, we don't know for sure, but this could all be epigenetically programmed when you're a fetus, right? So I think we have to kind of look at the epigenetics and study some pediatric populations, which I'm really lucky to partner with Jessica Tournier at U of M. She's got a great pediatric cohort that we're building. So I think we don't know. We can speculate, but
Great.
Good question.
We have two more outstanding lectures, again, that really focus on breakthroughs in our understanding of diseases and treatments that allow better care for our patients. And our next speaker is Dr. Richard Edelson. Dr. Edelson is a professor of dermatology at Yale. And while at Yale, he served continuously as chairman of the Department of Dermatology from 1986 to 2022. And at overlapping times, he has also been director of Yale University Comprehensive Cancer Center, the Yale Deputy Dean overseeing all clinical departments, leader of Yale Medicine's Cancer Center's Lymphoma Research Program, and faculty representative to the Yale New Haven Hospital Board of Trustees. After serving as departmental chairman for 37 years, he resigned the position but remains a full-time professor of dermatology. And like all of our speakers today, I could spend another half hour talking to you about all of his awards and accolades over the course of his career. He is best known for two discoveries in their development. First, he introduced the unifying concept of cutaneous T-cell lymphoma as a malignancy of skin-homing CD4 positive T cells. And second, he devised extracorporeal photochemotherapy, which became the first FDA-approved immunotherapy for any cancer. And as all of you know, immunotherapy is really the standard of care for many malignancies that we treat today. It is a pleasure to have Dr. Edelson here, and he's going to tell us the story of extracorporeal photopheresis. Dr. Edelson.
Good afternoon. When Tony asked me to speak about the story of how ECP was invented, presumably by me, it came as a surprise because of all the talks I've given remotely on the subject, no one had ever asked me to speak about how it happened. And so thank you for giving me the opportunity, Tony, to dig through the past and put it together. But thinking about how to make this perhaps a little more relevant to everybody, I can tell you that first is going to really put things in perspective for how things are rocketing ahead in that field right now, but also it's a great story, I hope. I'm a little biased about how to make discoveries and have that experience yourself by befriending serendipity. Okay, so I think I can start by just pushing this. Okay, good. So as a disclosure, I was the inventor of ECP, and for some time at the outset was financially involved. That was long ago. Now, as the science has continued Yale University started a company called Transimmune, to which a bunch of inventions coming out of my laboratory have been patented and licensed. That company is not yet commercialized, so I think I'm speaking quite candidly. Let's talk about serendipity. Serendipity is very different from luck. Serendipity is defined as the chance occurrence landing on the prepared mind. It doesn't become serendipity unless you do something with it. We as dermatologists see serendipity all the time at work. We may ignore it with all the patients that don't have the good manners to have complied with the textbook. Our lives are the result of serendipity. And this invention was the result of serendipity. It could not have happened without it. Each of ECP's defining features, shattered primary tenets of immunobiology. So we couldn't have done it on purpose in accordance with those tenets. Selective targeting, very selective targeting of tumor-specific antigens at a time that they weren't supposed to exist. Selective tolerance to tissue antigens. Immunopotency without adverse reactions. When I was cancer center director, trying to convince oncologists that you could have a successful and potent therapy that doesn't hurt people was a Ripley's Believe It or Not. Just to jump ahead to tell you where we're going to go, because this is not just the old story. It's where the old story led. And you may have heard of ARPA-H, the Advanced Research Projects Agency for Health that was started by the Biden administration. It's a new agency with $2.5 billion to give out to high voltage projects. And I'm happy to tell you that we got the first one because of what ECP taught us. And the goal is rather ambitious, to make vaccines on a personalized level against cancer, a broad spectrum of cancer, against the emerging microbes, do a better job than those vaccines that saved humanity with the COVID-19 epidemic, but had their flaws, for transplant rejection and autoimmunity, so a big order. So how did this start? I had to review this myself because it's been a while. It started as an offshoot of the very unpopular war at the end, the Vietnam War. Every male graduate of medical school in the United States was being drafted out of their internship. And the best thing that you could do is fib to the interviewers at the NIH and tell them you were interested in research. And if you could get chosen as one of the 150, you could then become called, believe it or not, wearing sneakers when you went to work, lieutenant commander, and you could fulfill your military obligation. But they were smarter than we were. They figured out that we were interested in research, and most of us stayed on. So, interestingly, I thought this was original before Rick Sontheimer's. But these are timelines that you can take off of PubMed. At the time that I arrived, long ago, at the NIH, T cells were that rare of a title. Human T cells were just being identified, to put this in perspective. And I was fascinated. I'd been allowed to finish a first year of residency in dermatology. That's what it was, that's what they allowed you to do as a deferral. But I was fascinated by what was, of course, mycosis fungoides, particularly in those days, and these portrait microabscesses, which were pathognomonic for the disease. If it's pathognomonic for the disease, I reasoned, it must be related to the cause and the evolution of the disease. And so I became very interested in that, and it turned out that we showed that they were invariably T-cell malignancies. And if you look, I got the arrow here, inside the portrait microabscess, even by light microscopy, were these dendritic cells of the epidermis, the Langerhans cell, and the malignant cells, only malignant cells being allowed in the portrait microabscess, so they were exclusionary somehow. They were hanging off the dendritic cells like grapes on a vine. So that's what I investigated there. And now if you look at another one of these timelines, cutaneous T-cell lymphoma could not have occurred as a title in a paper before that, because ours was the first one. But I didn't take it seriously yet. I still was ready to go into my father's practice in New Jersey. And it was my secret. It didn't happen. It didn't happen. Now, some of you may remember the actor Alan Alda. He was hired by Audible.com. Some of you may listen to books on Audible.com for a special that they put out called Soldiers of Science. And you probably recognize right here, there were 8 of us, young Tony, all right, Tony Fauci. And if you wonder how long this has taken, this is what I looked like then. But if it's a good read, and it's free. Another one of these, leukapheresis. So the message that you should be coming together is that ECP did not come out of thin air. Leukapheresis was new. We take it for granted as a physical removal of leukocytes from the blood under different circumstances, but we took advantage of it to treat a patient. So this patient that was flown in from Los Angeles, because we were able to do that at the NIH in those days, had an unusual leukemic form of the Sézary syndrome. Very high count, as you can see there. And he said, by history, that his skin involvement, his erythroderma, waxed and waned along with major changes in his white count. The higher the count, the clearer his skin. Then there would be a drop, like here. We followed that. It's a little hard to manage this. And his skin was worse. So we had no good therapies for this. And so we decided to use intensive leukapheresis to take advantage of this shift. Still not understood how that happened or happens. And we removed literally pounds of his leukocytes, his malignant cells, T cells, and reported that in the New England Journal. But this was a key publication for a couple of reasons. First, it wasn't the only time that I had a title that said successful management that was not successful, because his disease came rip-roaring back. We were only emptying the bathtub from the top with the faucet running. So we were doing nothing about the actual cause of his elevation of malignant cells. But the reason that that's important is that when we got to photopheresis, which was an effort to do better, to injure the cells and have them removed by the reticuloendothelial system as we get to, we knew that leukapheresis wasn't good enough. Taking the cells and throwing them away, or putting them in freezers, we didn't do it. And so when we saw the results that I'm going to show you, we knew that it was because of the plate and the return of the damaged cells to the patient. We used 8-MOP, 8-methoxysorolin, learned from dermatology from PUVA, and we had gone to great trouble to develop monoclonal antibodies against the DNA photoaddicts, the drug binding to the DNA, and as shown with that green dotted line, at a point when virtually all the yellow line, the T cells that were irradiated with the ultraviolet light outside the body, as I'll show you, were practically dead. Monocytes survived, which was very important, and we'll come back to. But we only were adding, as we could measure, 3 photoaddicts per million base pairs. So 8-MOP is the most titratable, finely titratable chemotherapeutic agent that there is, because when the lights go off, the drug returns to its biologically inert state. So we were able to control the level of cell death and the rate of T cell death to avoid tumor lysis syndrome, which is a fatal circumstance. Okay, so now we get to the treatment. So the treatment, which involved giving Sorolin, first by mouth, but later as a solution into the flow system, with the patient lying flat on a blood donor couch, antecubital vein cannulated, blood passed through the leukapheresis machine to lower the hematocrit of the monocyte lymphocyte-enriched population. So the hematocrit was only 2%, which allowed the light to pass through, and then pass through a plate, which I know was not done and designed intelligently, because I designed it. I thought that 1 millimeter was a very thin film, not from the point of view of a leukocyte, but that's what it was. And then return the cells to the patient and depend on the reticuloendothelial system to remove them. The idea being that we would be able to do much better than leukapheresis in destroying cells. But the strange thing that happened, and of course, this was the first report of ECP. This was the first ECP apparatus, finally named Rube Goldberg. I used to wheel around. I couldn't make the corners. It was then Presbyterian Hospital, so it was dented. This is 2 iterations ago of the actual apparatus that many of you have seen. Fancier, but no different. Think, how many treatments do you know of that were so far ahead of their time that they haven't changed, literally, in any meaningful way over 40 years? It's a tremendous accolade to my, I'm no longer attached to that company, Theracos, which used to be Johnson & Johnson, and now is Mallinckrodt, to the very, the very outstanding sales interactive team to keep this going. But it hasn't changed. Now what happened here was stunning. Knock your socks off, stunning. Because what I expected was that we would first show that you could actually shine light on the blood, activate a DNA cross-linking agent, and give the blood back to the patient safely, which wasn't known because nobody ever reported that before. But we were going to do the phase 1 safety study, and if treating the patient only monthly did not lead to serious sequelae, we knew that we were treating such a small fraction of the malignant cells that we'd have to come back and treat them every day to get ahead of the rate of production. But after only 3 cycles of 2 treatments back to back at 3 monthly intervals, the patient, who had been erythrodermic, his hands were fissured from the disease, We walked into the room and he was clear. Now that doesn't astonish you. Nothing will. The question is, what do you do about it? The first you say honestly to yourself, not in these words, I don't quite understand what happened. Something happened. Then you see it in the second patient out of the first 5. And now you have a problem. What are you going to do about it? Okay, that reported in the New England Journal. This was the first study. It wasn't chicken. What do you do about this? Do you simply walk away from this? You're a CTCL doctor. You've got a treatment that works way better than anything else ever tried. I'm a physician first. I knew I was in for trouble, right? But there were ahas. First, patients with CTCL, particularly then, when they died, they most commonly died from immunosuppression and opportunistic infections. These patients were not dying. We had treated only 5% of the blood, leukocytes, malignant leukocytes, and given them back. This was an immune reaction. But that immune reaction was selective. Now we've heard, and I'm a fan of CAR T, but CAR T treats all B cells to get rid of the malignant ones. All B cells to reprogram the immune system, hopefully, in autoimmunity. This is an entirely different level than anything I could imagine or my colleague could imagine. We were knocking off the malignant cells and nothing else, as far as we could tell. That was new. Immunologic dogma at the time said there was no such thing as a tumor antigen. Of course, that's not the case today, but it was then. There needed to be something that wasn't thought to exist, tumor-specific antigens. How could you attack it otherwise? No one thought that you would use the immunization route intravenous to immunize. Anybody get a vaccine that way? This was different. And it was different because it was cells that were going back in. The safety profile, to my knowledge, there's never been a patient reported who was responding to ECP, now much later, over millions of treatments, who had to stop the therapy because of adverse reactions. Mind-boggling. But most important, when we ruminated about this, the fact that there was not an explanatory immunologic mechanism was good news for us, not bad news, because this was going to be something big that we could discover. I just didn't know it was going to take so long. That was the prize. It's the definition of a disruptive innovation. Everybody in investigation wants to make a discovery like this. Let me tell you, they should be careful. You think that the telegraph industry welcomed Alexander Graham Bell? Doesn't work that way. It was irresistible to us, and a team came together of the same spirit. Let's uncover the principle. Couldn't do it in my father's practice. Then it got even more interesting. My patient with very therapeutically resistant pemphigus, we treated her. Didn't make sense. If we were immunizing, why would we treat her? maybe we could immunize against the disease causing T cells. That was a wild thought. She got better. Then colleagues at Columbia said, let's try this on therapeutically resistant heart transplants. Here you see lots of T cells invading the myocardium, destroying the myofibrils, and it worked even faster. What is going on here? Then a group in Austria studied acute graft-versus-host disease. And if you look at the first double column, and you're looking at the red-orange, you see that overall, 60% of these therapeutically resistant graft-versus-host disease patients responded. In fact, in the slightest cases, stage 2, all of them did. And as you know, 2/3 of the use of this treatment is now in graft-versus-host disease. So how many therapies do you know that work both as an immunizing treatment and as a tolerizing one? Something big is going on here. Now, just on the basis of this clinical efficacy and safety profile, no explanation, but we're working like crazy. In 1988, it became the first FDA-sanctioned anti-cancer immunotherapy. They didn't call it an immunotherapy because we didn't know that it was an immunotherapy yet. But T-cell immunity and tolerance. Let's go back. Roughly 350 centers throughout the United States and Europe now, a large majority, thanks to the efforts of the Theracos team. Almost every major medical center has a unit. More than 3 million treatments have been delivered to more than 80,000 patients. 1,000 plus peer-reviewed original publications. An exceptionally favorable selectivity and safety profile. Clone specific. Unheard of. So there was only one way to explain this grossly. There is an immunotherapy that just doesn't get credit as an immunotherapy. It's called the natural immune system. It works in excess of 99.99% of the time. The only time you ever think about it is when it fails. But as you're sitting there today, it's protecting against you against pathogens that you don't know are invading you. And at the same time, it's tolerizing you to your own organs. So this was beginning to look like we had landed on a connection, a tight connection with the natural immune system. Still a novel. Okay, now, 3 New England Journal articles. The original one about CTCL, that trial that led to the FDA approval. The heart transplant one, and in the largest ratio of authors to patients, the first face transplant patient. And they all start with the line, by an unknown mechanism. Not my goal. Now, my father, not bitter about the fact that I didn't join his practice, put this together from all of the publicity that we got. And he said, kid, because I was a kid, you were like a bad photograph. Overexposed and underdeveloped. You want to go into a hole and figure this out. Now, the key was the evolving science of dendritic cell biology. We've heard about plasmacytoid dendritic cells and monocyte-derived dendritic cells. Ralph Steinman, who won a Nobel Prize for the discovery of dendritic cells in 2011, was a close personal friend, neighbor, and advisor and colleague. He died shortly after the vote to give him the Nobel Prize because the attempt to treat his pancreatic cancer, worldwide effort, failed. And the sense was that dendritic cell therapy was basically impossible, another impossibility. The problem was, as Ralph understood, no one knew how the body makes monocytes into dendritic cells naturally. So invented was a way to do it for the laboratory. Very high concentrations, unattainable in vivo, of cytokines to coax monocytes or force them into the pathway. But these cells, when they were given back to patients, were junkies. They weren't exposed now to the same concentrations of cytokines that were required to make them, and they died. But somehow we assumed that ECP was making dendritic cells. And since we weren't doing it on purpose, at least not initially, it had to be physiologic. So PDCs are plasmacytoid. These are abbreviated, not to be confused with them, as PHDCs, we named physiologic dendritic cells. And if we were right, we had to be making dendritic cells, which are the master switch of the T-cell immune system, which controls most B-cell production of antibodies. And so if we were right, it had to be happening in the plate, because the plate was the only difference between leukapheresis and ECP. What could be happening in this plate? This just emphasizes the central role of dendritic cells in all T-cell reactions that are antigen specific. But there was a gaping hole, and the gaping hole was no one knew how to make them, how to make physiologic dendritic cells would actually work. But if they were being made in ECP, by definition, they work. So, to make a very long story very short, because I was only asked to give a talk about where the idea came from. That's my out. I'm going to give you the rest of the story in 2 or 3 slides. First, it started to break in 2002 with this cover picture of a dendritic cell that we were making on the cover of Blood. And here's another version of the dendritic cell, the green fluorescence, with pieces of CTCL cells that have been injured by APMOP, that have been eaten by the dendritic cell, and are now being processed. How did we know that we were making dendritic cells in the plate? We had of course, a group of patients that were being treated, and we could take the blood from these patients. Instead of returning it to them, take a sample and measure, as shown by the green bars, the expression of the dendritic cell early marker, CD83, on activated HLA-DR positive monocytes, the precursor of these dendritic cells. They were making, these were patients with CTCL that were being treated, patients with graft versus host disease, but this was a normal phenomenon, not a disease phenomenon, because 12 normal volunteers were also doing the same thing. Huge numbers of dendritic cells were being made from their passage monocytes within a day. And we measured which genes were being activated, and amongst the 498 genes which were being activated in all treated blood monocytes, these markers of dendritic cell function and evolution, maturation, were very prominent. We were turning on genes somehow in the plate that taught these cells to become, these monocytes to become dendritic cells. 60% of them. Watch this. This is blood. Now we're watching it as it's passed through the plate. And you see the larger cells are monocytes. Remember, T cells were being killed by the MOP. And those little dots are platelets that are stuck to fibrinogen on the plate. These monocytes are literally jumping from platelet to platelet. Okay, I gotta go to the next slide. How do I get out? There we go. Now what we needed to do is we needed to prove that these dendritic cells were the result, were the reasons that ECP works. So we had to accomplish another feat. We had to reduce that large plate and machine to something that would be fit for a mouse. It was a 500-fold reduction, and we took the ECP plate and we reduced it to this, with the understanding that our data showed that they were identical in their in effect on these monocytes that were passed. We also knew that we would ultimately be able to stack these small plates to make it scalable from mouse to man. And in a nutshell, with a tremendous amount of experimentation, we demonstrated that we could successfully immunize against mouse melanoma that's already established. It's relatively easy to prevent experimentally cancers. That's not the way it works in humans. Humans don't come to you with the cancer that's going to happen. You have to be able to treat it. So melanoma, ovarian cancer, colorectal cancer, we were able to eliminate them. Not huge tumors, but a good start, a solid tumor. Now, one of the other things that became clear is that immunotherapy, immunizing, is more like lighting a match and then lighting a forest fire. You don't need a tremendous number of cells. We needed many fewer cells. So here's this, I'm just about done. So here is the sequence that actually happens, proven. The plastic of that plate acts as a substrate. If you're interested in reading more about it, there's a reference in Science Advances 4 years ago. Fibrinogen, not polymerized in the blood, but very abundant, sticks to the plastic just as it sticks to collagen in wounds. Well, see, we didn't discover anything. We uncovered a natural phenomenon happening in the plate. The fibrinogen now has coated the plates very quickly. The platelets come through, and they stick to the gamma chain of the fibrinogen, and they get activated. And they immediately flip preformed P-selectin to their surface. Now the monocytes come through, and on the surface of the monocyte is PSGL1, P-selectin glycolipid 1, which binds naturally to the P-selectin on platelets. That's what happens in wound healing and clotting. These P-selectin molecules, these PCGL1 molecules on the monocyte, then move to the pole that's attached to the platelet and form a very strong bond. That's why those platelets look like they were jumping. The monocytes from platelet to platelet. And that forms a strong synapse. Calcium is released inside the monocyte. NF-kappa B is formed, which moves to the nucleus, activates those DC genes, and voila, you have a dendritic cell. A cell that normally is only 0.1% of the population of circulating leukocytes, because you don't need them in the blood, you need them in tissue. But now you can put them in your hands. So, what's happening now, and the reason why we got the large grant, is because we've already done, finally, recognition, we've already done a vaccination against a tumor once. It's called regular ECP for CTCL. Call it what it is. But you can do better by adopting the mRNA technology that led to the COVID vaccines, but improving upon it. And basically, it turns out that it's very easy for us now. We had to work on this, but it's very easy for us to transduce by getting the mRNA into these dendritic cells. They take it up like a sponge, and teaching them any trick we want. We can put on the surface of a dendritic cell functional checkpoint inhibitor antibody. Dendritic cells don't make antibodies. But now you've got a dendritic cell with all of its properties, with a checkpoint inhibitor, and we can put any antibody on the surface. We can teach them to squirt large amounts of the toxic interleukin 12. And of course, to process the relevant antigens, which they can select. So, finish, we have a new problem. The problem is focus. The menu of what can happen now is huge. But that's where this is now. And it started, it never would have happened without ECP. So I just want to thank, we've had collaborators galore around the world, but this is the primary team inside the laboratory, and this is the primary team outside the laboratory. So thank you so much. I really appreciate the invitation.
Thank you, Dr. Edelson. Any questions for Dr. Edelson?
Do you believe all of this?
So I'll tell you, when I was a resident at the University of Miami, I don't know if Rashmi's still here, but she and I trained there. In dermatology, we were in control of extracorporeal photopheresis. So, you know, we would admit Sézary patients all the time. We would admit patients with chronic GVHD. So I saw people being treated. But I'll never forget one patient when I was on call as a resident. I went to see her at Jackson Memorial ED. She was a young African-American woman, maybe about 36, 37, a mother. And she was admitted, she was there in the ED with shortness of breath, and she ended up having eosinophilic pneumonitis, probably the highest peripheral eosinophilia I've ever seen. I can't remember what it was. But she was erythrodermic. So to make a long story short, we did biopsies, we did flow cytometry. She had Sézary syndrome. And you probably know Francisco Curdell, probably my most important mentor in my training. So we funneled her over to his clinic. That's where the ECP was. And I'll never forget, you know, a few months later, being in his clinic, and he said, that patient you saw in the ER is there, if you want to go see her. And I walked in the room, and she was completely clear, like to the point where I didn't even recognize her. She looked completely normal, like my jaw almost dropped. And I think that was the moment when I realized the power of ECP. And so a question I have for you is, do you think we're optimizing it? Why can't we get more patients that response? Because we don't see it in everyone.
Right to the core. Okay, so the first thing is the patient has to be immunocompetent. So you can't effectively treat a patient with an immunotherapy like this, which is really not, this is an immunotherapy that requires the patient's T cells to help, unless the patient is immunocompetent. And by the time we see Sézary patients, maybe 1/4 of them, the simple test is to look at their total CD8 count. If their total CD8 count is near normal, 80% of them will respond. Maybe not completely, but very meaningfully. But if their CD8 count is at HIV advanced levels, very low, 0. So first the question would be, were those patients immunocompetent at the CD8 level? Mm-hmm. But think about what has to happen. You have literally billions of malignant cells in the tissues and circulating. The immune system has already been overrun. That's why the disease got to that point. Now what you need to do is you need to turn it around. And turning it around is not as easy as you might think, right? So the most amazing thing is that it worked at all. Now what the dendritic cell has to do in regular ECP, it has to identify the damaged but still intact malignant T cells, internalize them, digest them, extract the tumor antigens, and move them to class 1 MHC on the surface. You can make that happen much better if you use the mRNA approach. So there's huge amount of improvement. And what I know, it's funny how dogma happens. I was there. I know how crude my invention was. Hats off to the Theracos team for keeping the ball in the air. I never expected that approach at that time to turn into a worldwide therapy. We can make it much better. There's another thing that you have to remember, that if ECP is on the one hand immunizing and on the other hand tolerizing, two things are happening at once. You're only going to see the immunizing effect or the tolerizing effect if they dominate. The car is being driven with the brakes on. So there's an easy way, a very easy way, to make it only immunizing or only tolerizing. If you turn the lights off, there is no activated AMOP. There is no damage that's done to any of the cells, including the monocytes, and they become universally immunizing. If you turn the lights on, there's a Gaussian curve of the exposure of the cells that go through the 1 millimeter thick film. A lot of the cells are spared, monocytes, and they become immunizing. A lot of the monocytes are roasted. They're close to the surface, and they become tolerizing. So if you want to make it more universally tolerizing, all you need to do is make the 1 millimeter film 1/4 of a millimeter. Skew it towards roasting. So there are many steps that can be taken. It's amazing that it works at all.
There have also been, it's been studied, as you know, fairly well in scleroderma. There's reports at least of ECP working well in numerous chronic inflammatory diseases. You showed your patient with pemphigus. Do you think that where we're headed in the future, ECP could be a truly a viable treatment for chronic inflammatory diseases, given everything else that's in the pipeline? Do you think what's going to happen in the future can make it better for treating those diseases?
Okay, now this is a statement that should be weighed for my bias. The level of specificity that is attained with the crude situation as it exists far exceeds anything else out there. The toxicity is far less. I'm not satisfied, so I think the mRNA is the way to go. But what you have to remember is that the dendritic cell needs the immunizing or tolerizing antigen. In transplant, it is the tissue that's been attacked that provides the antigen to the circulating monocytes that go through the apparatus. So the antigen you're tolerizing to is the heart or the lung or the kidney or the liver that was damaged. In autoimmune disease, there are a few autoimmune diseases where we think we know the antigens. There are a lot of autoimmune diseases where we don't. So that's a stumbling block. But what's going on now, we have a colleague, Phil Santangelo at Emory, who is absolutely a magician with the mRNA. He is now extracting all of the mRNA from target tissues, easiest with cancer, and letting the dendritic cells select the right antigens. If that works, maybe we have a shortcut.
Great. One last question for Dr. Edelson, if anyone has one. All right, well, I thank you very much for your presentation. I've thought for quite a while now that we're not harnessing the full power of ECP, and I'm glad you're doing future research and that you're involved in it. Thank you. Okay, our final presentation for this afternoon, we will welcome Dr. Dave Fiorentino back to the stage. And again, since I introduced him earlier, I am not going to go over his full biography, but he is full professor at Stanford University. One thing I didn't mention about Dave earlier is that he is one of the founding members of the Rheumatologic Dermatology Society, probably my favorite society. It's my favorite meeting to go to. And he's going to talk to us about the present and future insights into the pathogenesis of cancer-associated dermatomyositis. Dr. Fiorentino.
I'm almost sorry to be giving this talk since everyone's falling asleep here. Okay. By the way, there's another founding member of the RDS there in the back, Dr. Rick Sontheimer. So, okay, so here's what I almost feel like everyone should just stand up, relax a little, because I don't want to lose it. I want everyone to just, I think this is an interesting story. It's a story much like smaller scale, but much like Dr. Edelson was talking, but it is a story. And I want everyone to just follow it. It's not that complicated. But I think when you don't have a time, I finally have an hour to explain it, so this is great. So I'm going to talk about cancer, really cancer and rheumatic disease, but our model disease is dermatomyositis. And this was just something that has been fascinated me since I was a medical student. I didn't understand. I was like, why do you get a cancer when you get dermatomyositis? I don't understand that at all. Like we learned like paraneoplastic, like small cell or oat cell carcinoma secretes these factors and then it causes, you know, all these changes. But like, I don't understand this. What's the link? It made no sense to me. So we'll talk a little bit about that today and explore it and hopefully just get you thinking more about it. I think once you've done with this, you will think a little bit differently about it. And maybe you can help me and you'll have some ideas. So first we'll start with the patient. So this is someone I saw. She was, I guess, 59 when I saw her. I'm just going to go through this pretty quickly. She had cold hands and feet. She lived in Oregon. I had never met her yet. For a few years, didn't really think much of it. Got a rash in 2008 on her hands. Someone finally, an astute dermatologist, finally thought this might be worth biopsying, and it looked like dermatomyositis to them, and she was given that diagnosis of clinically amyopathic dermatomyositis in 2009. It was fairly well established that that is a thing. She had a positive ANA, but everything else was pretty normal. She, like any good dermatologist, underwent cancer screening because we don't know, does this person have a cancer? Is this one of the 15% in the US that's going to get a cancer in 3 years? Complete cancer screen was normal. Started to get elevated muscle enzymes, started to feel weak. Unfortunately, she ended up actually transitioning into more of a classic presentation. By the time she got to us, she had an elevated CK and she was weak. And she looked like this, and it looked like dermatomyositis. We said we agree with that, but you know, can you give us some blood? Because we're doing research. We're just collecting blood from everyone. We actually don't even know why we're collecting blood, but we know it's going to be important someday. So we're going to collect some blood, and she said yes. At that time, we were just exploring with like literally taking blood from patients, doing immunoprecipitations from radiolabeled cell tracts and just cell extracts and just seeing what comes down. And so she had this doublet. It's a smudgy doublet, but this is kind of what it used to look like in 2010 when you were trying to find these things. And that antigen turned out to be what used to be called P155-140. Now we call it TIF1 gamma. And there was a publication came out within the next year from Ira Targoff's group that basically said this could be associated with cancer in dermatomyositis. So we called the, sorry, let me just go back here. So TIF gamma, okay, so before I get to that point, let me just remind everyone, there are, this is for Rick, there are autoantigens in dermatomyositis, so this may be something that we should talk about for tolerizing diseases to be tolerized to. But just remember, in dermatomyositis, there's really 5 cardinal antibodies. Remember that they're mutually exclusive. Those are the ones in red. They basically divide the patients into subgroups. You can detect them in probably 3/4 of the patients. And then there's a 6th group, which is the synthetase antibodies, which is like JO1 and all these, which is really considered a separate group of diseases by many people now. So TIF gamma is the most common one that you'll in a patient in the U.S. if they just come in with dermatomyositis. That's the most common antibody that you'll find. Okay, what is TIF1 gamma? It stands for this transcriptional intermediary factor. It does lots of things in the cell. Okay, a couple points about these antigens, and this is one you just want to get. Okay, TIF. That should be like part of your vocab for this lecture. TIF. I'm talking about TIF1 gamma. It like all autoantigens, almost all autoantigens in rheumatic diseases, these are antigens that are supposedly in every cell in your body. So TIF gamma does things that every cell needs to do. Tumor DNA repair. It acts as a tumor suppressor in most instances. It's involved in transcriptional regulation. Okay, so one question you might answer is, well, how in the world is that associated with dermatomyositis? Because this is some antigen that's in the nucleus, presumably, doing lots of things. Like, I don't understand the connection. None of us do, right? So that's one of the things that's so fascinating about these rheumatic diseases. But all we do know at the time is that it's associated with cancer. In every cohort it's ever been tested, it's associated with cancer. But except there's no association in the juvenile DMs. And juvenile DM patients make antibodies against TIF gamma, but they generally do not get cancers, as Dr. Sondheimer mentioned. So in the US, if you look at all the cancer-associated DMs, so cancer-associated, that means that from the onset of your dermatomyositis symptom, some cancer was diagnosed within 3 years, plus or minus. There's a window of 3 years after or before. That is considered cancer associated. And we're going to talk about why that's not a great, I don't think that's a great definition. If you look at all the cancer associated patients, about half of them will have this antibody, about half. Half will have other antibodies. Still can't get this. Okay, but if you're on the flip side, if you're dermatomyositis and you get diagnosed with dermato and you get this and you get told you have this antibody and you're in the US, you have about a 25% chance of getting a cancer diagnosis. So a lot of patients just come in and they think, oh my God, I have a cancer antibody, you know, this is really bad. In the US, chances are you're not going to have a cancer emerge. If you're in Japan, chances are much higher, which is very interesting. So more like 70%. 80%. Okay, so that's TIF. The problem is we don't know how to recognize the ones that are going to get cancer or not cancer. They look exactly the same, pretty much. The skin biopsies look the same. The CKs are the same. Everything's the same. So we have no way of telling, unfortunately, which ones are going to be the cancer patients. Go back, fast forward. Because we didn't know which ones are going to be the cancer patients, we called back, when we got this antibody test back, we called the dermatologist back and we said, we should maybe run another cancer screen on this patient. We had no idea what we were doing, but we said, well, it's a cancer antibody, maybe you should screen again. So this time, now you're at least 4 years after her rash and maybe 7 years after her cold, whenever you want to call her disease starting. She gets another screen and she gets a pelvic ultrasound and they find a mass and it's early stage, which is going to be important, uterine cancer. And she actually gets surgery and does great, which is a great story, great end to the story. But it brings up these, what I call these gaps, which is, first of all, okay, how is cancer connected to rheumatic disease? Second of all, how do we find out who's going to be the people who are going to be that develop the cancer? And if we're as clinicians, how do we screen for this? Who are we going to screen? And how often do we screen for cancer? I keep going backwards. So, okay. So cancer and dermatomyositis, just, this is a clear association. Now, I don't really need to belabor this point. All countries, it's associated. This graph, though, is the key to remember. This is the original New England Journal Medicine article, one of the first ones to really show in a population-based study that there is an increased risk of having a cancer be diagnosed, which is on the left, on the y-axis, around the onset of DM diagnosis. And so that kind of peak is what's important to remember, okay? We don't know why, but we know that's what happens. So, you know, there's a few times you just have to put your stake in the ground and say, this is what we know. It's okay that you don't understand it, but know that it's true. And this is one of those clues that's trying to tell us something. Okay, and we're going to talk about all this stuff. I'm just kind of trying to lay the groundwork here. Okay, so the question is, what's the link? For a long time, people said, well, there is no link. It's unrelated. It's because everyone's worried about cancer, so everyone gets screened more intensively. Or we're putting them on all these cytotoxic medicines, right? And they're getting cancer because these medicines cause cancer. Well, it doesn't explain a ton of things, but it doesn't explain why you're getting cancers before you get the diagnosis of dermatomyositis, first of all. And it also doesn't explain why the cancers that are the most common in a given, what I listed here is the cancers in Scandinavia on the left, from the most common to the least. And then on the right, it's the cancers when you have myositis. And some cancers go up in the list, some go down. If you were just screening more, you would just be getting more of the same cancers, but you're not. You're getting a little bit different story. Okay, so the other possibility is that they're related biologically, and again, I just think very simplistically, they could be both downstream of something, right? There's some shared, when you have dermatomyositis, you have a risk of getting both of them as a result of some process or something that's happening. obviously one could beget the other. You could go from chronic inflammation from myositis could cause cancer. We know that's a good paradigm for lots of things. Or the other way around, the cancer could somehow cause myositis. And now that, Dr. Edelson's given the talk, he's absolutely right. What's amazing is that people would have laughed at this in the 90s. Anti-tumor response, oh my God, that's a joke. This has been proven in mice that this doesn't happen. That's why you don't always listen to the mice studies, because it's not always true. But some great work by Dr. Schreiber and others, really right around the turn of the century. It's so sad that I'm old enough to say the turn of the century. I remember the turn of the century. But anyway, to really show that this happens. And somehow, maybe the tumor exists. You have a normal immune system. That's one of its roles is to fight cancer, right? Little incipient cancers that are transformed cells and eliminate them. Maybe somehow the immune system does its job there, but goes awry, and you get a rheumatic disease in the wrong genetic background. And I'm not going to go too much more into that, but just to say that the anti-tumor response is a pretty good framework to work with. It's not proven. I just want to say that right now. But everything I'm going to talk about from now on in, because you need some hypothesis to start understanding how you're going to interpret your data. So our hypothesis is that the cancer comes first, always. And so you may get dermatomyositis first, but you have a cancer, and that cancer emerges later. So it looks like the cancer came later, but it was always there. Okay, so I'm going to skip through some of this because I just want to get to I want to keep this relatively on track. So we're on track. So we're in this paradigm where, okay, I'm going to believe this for now, that cancer somehow initiates autoimmunity in the right circumstance. So the second concept you need to kind of make sure we're all acquainted with is this concept of immunoediting. And so some people call it the 3 E's. So I'm just going to go through this briefly. You have a normal tissue, okay? The normal tissue then starts to go awry, and you have a tumor that begins. Tumor antigens are expressed. Some cells get transformed. There's no immune response yet. But these cells are secreting, various chemokines that says there's something wrong. They're expressing antigens that says to the immune system there's something wrong. And finally, you call in the troops, and the immune system begins to recognize that tumor, hopefully. Bunch of different types of cells. We don't need to go into exactly all the different types of cells whose job is to really recognize that tumor. But one of 3 things can happen, right? One thing that happens, the immune system kills the tumor. Right? So that's the first E, elimination, right? And that's what we kind of all imagine that we hope happens in our bodies. And as I think Rick was saying, it's very true, right? If you think about it, we can't study the people who've won this battle, right? Because who are they? We study all of the immunologic losers, right? Those are the cancer patients. We only know what to study by the fact that they've expressed cancer. So, but this is a possibility at least, and this has been now shown, and it's basically accepted. This has been shown that you can do this in mice, and actually in humans, there's good evidence that this happens. Okay. The other possibility, though, is that the immune system works to eliminate the tumor, but the tumor moves, right? So the immune system tries to get a hand on the tumor moves. The immune system then moves to get the tumor moves. And by moving, of course, I mean, the tumor's shedding antigens, shedding MHC, secreting activating certain types of molecules and cell types that suppress tumor. And so the bottom line is you can get what's called equilibrium. So this is like this state, right, where the tumor's not detectable, totally under the radar. You feel fine, but it's there, and that is a metastable state, but it could last for years. Who knows how long it could last? At least years. And then obviously the scenario that is the unfortunate scenario is eventually the tumor does such a good job evading the immune system and acquiring more genetic mutations that it can escape. And I just want to point out here that there are cells in your blood system and around the tumor that are actually promoting the tumor. So this is something that, we always think about the immune system is all about eliminating tumor, but unfortunately there's other cell types in that stroma that are actually pro-tumor. So your immune system, depending on which way it skews, it can be a bad deal. So that's escape. So there's elimination equilibrium, and escape. Those are the 3 E's, okay? Those are the possibilities of what could happen. So what would you predict in an autoimmune disease? Now we're going to accept both of those frameworks. So here's the predictions that you would have in a patient that's going to get an autoimmune disease. Let's call it myositis for right now. There is some cancer. We said the cancer comes first, right? That's the green. The green, this is just a schematic of the activity, of whatever you want to call it. It's the activity of that cancer. It's how advanced it is, okay? And this dotted line would be considered, once the tumor gets to that stage, you can detect it. Either there's a symptom, you can actually diagnose the tumor. So it starts out totally undetectable, right? For some reason along the way, that immune response to the tumor eventually spills over to cause myositis, right? And so that's your time 0. Time 0 is when you get your first symptom of your rheumatic disease, right? I got a rash, the patient comes in. And the typical scenario would be, the most common scenario is that they both emerge together. So just think about that for a sec. That is amazing. Rheumatic disease, right? Rick just showed us data from John Harley, right, that it's a multi-step process. Years to develop a clinical autoimmune disease. Cancer doesn't happen overnight. Years to develop a cancer. And yet, these 2 diseases most commonly emerge within 6 months of each other. That is amazing. I mean, to me, if you think about it, that is incredible. And that is the most common scenario, right? The tumor has escaped, and it's synonymous with when the autoimmune disease escapes as well. And that's what we call cancer-associated myositis, right? But there's other scenarios, right? You could have the same situation where the tumor, there are genetic changes in the tumor or structural changes of proteins in the tumor that elicit an immune response that causes the disease, the dermatomyositis, but the tumor actually doesn't become clinically detectable. It stays in this equilibrium state, right? And it could be years, but it could escape, right? And so this would be a patient that has a tumor diagnosed, I don't know, 5 years later, 3 years later, 7 years later. You have a patient who gets a tumor, breast cancer, 10 years after they come in with dermatomyositis, you're gonna be like, well, that's probably not related. How do you know? How do you know that's not related? And then the other scenario, right, is the immune system eliminates the tumor altogether. And you come in with dermatomyositis and the clinician says, oh, good thing you don't have cancer-associated dermatomyositis. Again, how do you know? So the question that was fascinating to our group was that, why is it that most DM patients, even patients in this TIF group, TIF gamma, high-risk cancer, why is it that most of them actually don't? And in Japan, most of them do. So, but why are we seeing patients that don't? Is it just because malignancy is only one trigger for DM and you have many other triggers, right? The concept of rheumatic disease is that you're a genetic setup, then you have some environmental trigger or triggers. And maybe all those other patients were triggered by something other than cancer to get their autoimmune disease. That's all, that's the explanation. But what if actually malignancy is more commonly the trigger and the body's immune system eliminates the malignancy, right? And so the question is this connection between cancer, is the biology, are we looking into a window because we're seeing that rare patient with association of cancer and dermato, but it's actually giving us a clue into something that's much more widespread. So are cancers being eliminated in autoimmunity so that you're left with the autoimmune disease, but it actually was cancer associated. So that was the hypothesis that we had, is that some DM patients actually, quote, without cancer actually had a cancer, but it was eliminated. And that was due to an effective anti-cancer response. And then the second really corollary of that would be, and somehow we can detect that in the blood. That immune response that's reflective of a really good anti-tumor can be identified by antibodies in the blood, by specific antigens. Okay, so that was the scenario that we started with, okay? So we were interested, so we're studying cancer, right? So we took patients with, all these patients for this entire study were dermatomyositis patients with bona fide TIF1 gamma antibodies, okay? And we took patients that were either no cancer, meaning they didn't ever had a cancer emerge, or patients who had a cancer emerge within 3 years of their onset of disease. And we took each of these lanes is a serum from one patient. Each of these is a different patient, each of the columns, right? This is immunoprecipitation. So we took their serum, just saw how many antibodies, what everything that you can detect that serum binds and run it on a gel. Okay, so they all have this band because that's TIF gamma. That's the antibody. That's molecular weight of TIF gamma. So that's the antigen TIF gamma. So no surprise there. But, okay, so what's different about these two gels? You have cancer on the left, no cancer on the right. And if I ask, and you have like little kids, if you ask them, they know, they tell you right away what's the difference between the gels, right? What's the difference? Yes, right? There's so much repression going on in this room. I don't know if that's right. I don't want to say something stupid. Yeah, right? There's just more stuff, right? There's more stuff on the no cancer. So for some reason, and what's amazing about this, if you think about it, these are all different patients, these patients are all different, demographically, they had different cancers. I mean, you think about how different, the fact that you could see something just with this crude of a comparison is actually pretty amazing if you think about it. These are all different cancers. But yeah, it seems that if your immune system just focuses on this one, as far as autoantibodies are concerned, on this one protein, that is not good. And you are high risk to have a tumor emerge with your disease. But if you can diversify things, it seems like a good thing. Maybe, that's our hypothesis at this point. So what we did is we went and this is like not pretty, but we basically took each of these, we took these immune complexes and ran them, digested them and ran them out in a gigantic, mass spec and like just started sequencing like crazy and seeing what things start coming down. What are these antigens? And so we were able to, this is a little bit laborious of a process because once you get some potential antigens, you have to go back and validate that they're really making antibodies against that antigen. So you have to make the protein. And so we identified, here's 10 of them that we identified, okay? So there's 2 cohorts, one's at Hopkins, one's at Stanford. And you can see a couple things just from this. You can see, first of all, there's some antigens that are pretty common, right? Now, so these are the frequencies of those antigens in the cohorts, cancer and no cancer. But you can see like 30% of the cohorts make antibodies against this particular one, whereas like this one, these 3 were like private little immunomes. It's like that one patient had made those antibodies and no one else made the antibodies. So there's different levels of sort of how commonly they're shared. That's all you really know now, but that was interesting. We took this antigen called CCAR1 because it was so commonly expressed because we thought that was interesting. Maybe that's an anti-cancer, maybe that's sort of reflecting an anti-cancer response. And it seems like to be a common one, if that's what it is. So what is CCAR1? We were interested in it because when we started reading about it, it controls things that may be important for cancer. Apoptosis, cell growth. And there was actually a group that actually was making inhibitors of this protein to try to block tumors. So it seemed that it was pro-tumorigenic. So we thought, that's kind of interesting. It's somehow maybe involved in the tumor, possibly involved in the tumor process. And this is just showing you it runs on a gel. Okay, so the first thing we noticed that, remember, we were only looking for these antibodies in a patient that was high risk for cancer already. They had TIF gamma antibodies. When we went back and looked in DM patients that didn't have TIF1 gamma antibodies, we don't find this, we basically don't find this antibody. Okay, so it seems to be confined to the TIF1 group and it's confined to DM. So you don't really see it in lupus, IBM, all these other things. It's a DM specific antigen. So the real question is now, what happens, if you compare the groups? So then we went back and we tested all patients in the cohort. We have cancer data. We know if they had cancer or not. Is there a difference in cancer emergence in just the anti-TIFs versus the anti-TIFs plus anti-CCAR? And it appeared there was, but only if you looked in the narrow window. So if you define cancer associated as 3 years, you see a protection from cancer emerging. Okay, but if you start to expand the window, right, so you don't see the protection. That's probably because you're starting to get cancers cancers, you're including cancers that have no relationship to dermatomyositis, right? So this thing, we don't know when this antibody came up, but it's not going to protect something that came up 50 years before it, and it might not protect a random cancer that's not associated with DM. It may not be protective for. So it seemed to be associated with the window of when you would expect a tumor to be associated with dermatomyositis. Then we went and looked at, did a larger study and looked at and showed, yeah, it reduces the cancer risk. These are absolute risk numbers, standardized incidence ratios. So if you look at all the TIF gammas in the Hopkins cohort and the Stanford cohort are pretty close to the same, which is pretty remarkable in and of itself that the data are so congruent. But you see about a 3.5 to 4.5 fold increased risk of incidence in cancer if you're DM and you have a TIF1 gamma antibody. Okay, we kind of knew that. But if you add on, if you're TIF positive but you don't have a protective CCAR antibody, that risk goes up. But if you do have that antibody, if you have both antibodies, the risk goes down, and it's not statistically different from the healthy population. Okay. But we actually, initially I was bummed because we did see that some cancers emerged, right? And I thought, shoot, this isn't perfectly protective. So that's kind of, I was thinking that's a bummer, but maybe that can tell us something, right? Maybe if we look at these cancers, we'll learn something. So if you would imagine that a cancer that's emerging in a patient who has a protective anti-cancer response, maybe those patients will generally do better because they already have an immune response that's protective. The cancers may behave less aggressively. They may be at an earlier stage. And that's what we found. So the cancers that emerged, if you had this antibody, were much earlier stage. They were all early stage, actually, as opposed to the cancers that emerged with the DM at the same time without this antibodies there, many advanced stage cancers. And that's what we see in dermatomyositis, right? When you get the cancer right when they're having the autoimmune disease, those are the patients who can die of cancer. They get really fulminant disease. Okay, the second thing that was interesting, and this is what I wanted to focus on, is that this is that same peak of cancers that I mentioned. This is that was shown in the New England Journal Medicine article. This is time on the on the x-axis, number of cancers diagnosed, and the 0 point is right here. Obviously, all the cancers are diagnosed here. But if you look at across all the data sets, or a bunch of data sets where they have large enough numbers, you see this sort of shoulder. Okay, so it kind of looks like this. You have this narrow window that we consider cancer associated, and then you have this shoulder of just a few cancers popping up. And you never really knew, well, I don't know if those are related. It's hard. It's really, statistically, it starts to be difficult to deal with those numbers, and you start to lose power, and you think, well, I can't prove that that's more than I would expect. But they all generally have this shoulder. And so we were interested in this shoulder. And so one prediction, right, of this equilibrium model, right, would be that if you have an anti-cancer response, maybe it doesn't eliminate the tumor, but you keep the tumor in check for a while, and then the tumor finally arises, and that's what those are the earlier stage tumors. But you'd also just expect that they're going to occur later, right? So the tumors that occur with this antibody should be later than the tumors that occur when the patient's just focusing their immune response on the TIF gamma only. And so this was the striking thing that we saw, was all the tumors that emerged in the patients with the CCAR are in blue, and this is time after DM onset. You can see it's astonishing. If you don't have that antibody, vast majority of tumors grow with the autoimmune disease. They emerge together. But this antibody is associated with late emergence of the cancer. And so that is very consistent, again, with a model that perhaps this is reflecting an anti-cancer response. And so that dot right there, that's our patient that I showed you at the beginning. So she had CCAR1 antibodies, and her tumor emerged almost 4 years after the onset of her disease. So back now if we were screening that woman and I saw she had CCAR antibodies, I would be like, keep screening her. Keep screening her every year. I want to, this woman's, she's not young. She's a woman. I'm going to keep looking for ovarian or some kind of cancer. Okay. So this might explain this interesting study, which was done in China, where they took patients with ovarian cancer, and they looked at patients who got cancer after the diagnosis of DM, and after was defined as I think a year, or patients that were concurrent. And they looked at the survival, and you saw that the patients who got cancer late did much better than the patients who got cancer at the same time. So you're getting the message, right? Late cancer, it's kind of reflective that maybe something good is trying to happen. Simultaneous cancer, not good. So the late cancer is going to represent that scenario. The cancer's kind of caused DM, but it's going to pops up late. And then this is the concurrent. Okay, we also looked at cancer association with a bunch of these other antibodies, and several of them appear to be tumor protective. So there seem to be more than one of these. And it turns out that if you start looking at the number, how many of these different specificities you have antibodies against, you start to get basically almost in that group. So for example, if you have none of those protective antibodies and only have TIF, 70% don't have cancer, 30% get a cancer. If you have one of them, it's down to 15%. If you have two of them, we only had one patient get a cancer. And anything more than that, a cancer never was emerged. So they seem to be somehow additive with regards to cancer emergence. Okay, this was the piece I wanted to tell you. This CCAR1, we'll go back to this protective antibody. It's only in the TIF gamma group. You really don't see it in the TIF negative group. And so we thought so why is that? You know, why is this? It's like an add-on antibody. And so one possibility is that they could be in a complex, and you could be getting what's called epitope spreading, right? And so if you don't make antibodies against TIF, which is maybe where it all starts, you're not going to spread to the other things that it interacts with. So it turns out they do interact, CCAR and TIF. So that would be consistent with epitope spreading. Okay, so now other groups have published on another specificity that also appears to be cancer protective in the TIF group in DM. It's called SP4 is the antigen. Same kind of story here. Protection from cancer associated with decreased risk. What about kids? Because the question was, what do juvenile patients, they don't get cancer. So do they make these antibodies? And the answer is yes, they do. But they make them in different frequencies. So you can see like this particular one, the SP4 is the most common, and CCAR is like down here. And you can see there's all kinds of combinations. Many patients make multiple antibodies against multiple of these antigens. And so that's the key. I want to give you the message that these antibodies occur together much more often than you would expect by chance. So it seems like there's some sort of, they're reporting on, maybe this is all a complex, a physical complex in the cell that has to do with cancer-induced DM. But there's definitely some sort of we call it a network between these antigens. And we keep finding new ones, and they keep being kind of in this network, okay? So we've done this a lot in this group. And so I'll talk more about that in a second, but I just want to say, okay, so you're in the clinic, you can't test for CCAR1, right? So how do I know if this patient's CCAR? I told you that you can't really tell clinically if you're going to have a cancer, if you're in the cancer emerged versus not emerged group. But it is interesting that the Hopkins cohort, our adult cohort, and the juvenile DM cohort are all sort of indicating there are some clues, okay? And so I'll just give you the punchline here because that you can see the data. And that is milder disease, so milder muscle disease. So the patients tend to either have, they may be often amyopathic or have very low CKs. They tend to more commonly have Raynaud's. Matter of fact, if you have Raynaud's, it's very rare you have this antibody. So Raynaud's is kind of a good thing. And less ulceration, which is interesting. So the only skin finding we could see that was different between CCAR1 positive and negative is that the CCAR1 positive patients almost never get ulcers on their skin. This again, remember, these are TIF gamma only. Don't forget MDA5, we're only talking about the TIF group. So these would be patients that I would say, you know, maybe you can say, okay, they might have one of these protective antibodies. Obviously, we can't act on this yet. The serology is going to be the more powerful way to do it, not the clinical presentation. So the model here that we developed is that you have some cancer, okay? And you have some TIF1 gamma. We think, my gut here is that because of the data in other systems, that TIF1, this whole complex, it functions generally as a tumor suppressor. It's generally probably what's happening in most tumors. But once you have a cell that goes tumorigenic, you get something changes about that TIF protein. So either it's mutated, it's overexpressed. We don't know why your immune system starts to recognize that protein. Okay, that gives you an immune response, which is the color. That means you've broken tolerance to that protein. And you get dermatomyositis, by the way. But our hypothesis is that tumor response is actually a pretty cruddy one. It's not good for anti-tumor. And that's why I believe that has revealed to us this connection between rheumatic disease and cancer, because the anti-cancer response that often is very effective in this situation is not very effective. And so now you start seeing patients, wow, that's so weird. They got cancer and DM at the same time. That's so odd. But if you're able to spread your immune response to CCAR1, other members of that complex, SP4, other members, then you get maximal cancer protection. So that's sort of the model. So the question is, if you go back and look at all of our TIF-gamma patients, so that's the high-risk cancer patients, and you say, how many of them are accounted for that don't have cancer? How many of them are accounted for by this network of antigens, right? And it's about half. So that explains half of our patients who don't have cancer, if you buy into that's what's going on here. About a quarter of them express MY2 and TIF antibodies. I mentioned that these are usually mutually exclusive. This is the only one that's not. And there is something very interesting about MY2 that's associated with cancer protection when it's in combination with TIF, but we don't understand that. But you still have over a quarter of the patients. What about these patients? Are those also cancer initiated and we haven't identified, the protective immune responses? Or maybe this is the group of TIFs that totally it's not cancer driven, right? Maybe this is like the juvenile patients who make antibodies again. This is like vaccine, sunlight, whatever, you want to say. So we don't know. We don't know if we're still left trying to, but the more we discover, we keep finding them that they fall into this group. And so it's making me less sure that we're going to find a whole nother hub of antigens that are associated with cancer protection. This might be it in that group, but in the TIF group. But what about all the other serotypes? I mentioned there's 5 antibodies. So it turns out all of them, except for possibly MDA5, are associated with an increased risk of cancer. So could this be happening in all these other groups? So, and I'll just, long story short is I think we're doing this with NXP2, we're seeing the same thing. So there's protective antibodies. Some of these responses though, excuse me, yeah, so I'll leave it at that. So we may have a large, we may be seeing the tip of the iceberg. So in other words, we're seeing the cancers that emerge, but we're not seeing really the patients who have cancer-associated rheumatic disease. And how big is this iceberg under the water? We don't know. So we need, but I think the answer is going to be hammering at this serology and knowing our patients, typing them very well. And like I think Dr. Edelson said so nicely, is that there's really not that many systems where we can study natural cancer immunity in a human being, right? Checkpoint inhibitors are not natural cancer immunity. We're inducing cancer immunity. It's great, but photopheresis, right? You're basically just you're immunizing and putting it back in and watching the natural immune response happen. Autoimmune disease, I believe, is the same thing. You're seeing this is a way to get a window into understanding how often and how does natural cancer immunity work. Instead of studying patients with emerging cancers, I believe that we should be studying patients with these high-risk cancer diseases that don't have cancer emerge. And so finally, I mentioned a little bit about the TIF-gamma antibodies. I believe that the patients who have just the focus on the one TIF, that gel is clean, they just have that banded TIF, those are the patients who often have a cancer emerge rapidly and destructively. So I mentioned why do I think anti-TIF1 gammas maybe even aid and abet the tumor in addition to causing or being associated with dermatomyositis. And it comes from another study in China, another ovarian cancer study, where they matched these patients. They took patients who had ovarian cancer and not ovarian cancer. So I'm sorry, ovarian cancer associated with DM and not ovarian cancer that's not associated with DM. And they just looked at survival. And they matched them on every single thing that they know that has to do with prognosis for ovarian cancer. And still, the non-DM patients did much better than the cancer associated. We know now that most of the ovarian cancers are TIF. So these are probably almost all, if not all, anti-TIF patients. And you can see that the survival is just worse. And so these are presumably all these patients that are focusing their immune response on TIF and not doing well with overall or progression-free survival. Second reason why I think this may be true is that is that there's in our cohort, and if you see a lot of these patients, DM patients, how many people have seen a DM patient with a cancer? I'm just really curious. Okay, how many patients have seen a DM patient in the same patient have more than one cancer? Yeah, okay. So it's not as rare as a hen's teeth. I mean, this happens. We have multiple patients like that. They get one cancer diagnosed, then a year later, another one pops up. So that is not super consistent with a unidirectional tumor to immune response, right? To autoimmunity arrow, to direction, right? Okay, I can see how one would cause it. Why did the second one come up? And it's in the literature all over the place. Multiple cancers, synchronic cancers, synchronous cancers, second primary ovarian, metachronous cancers, et cetera. So I think that's also giving us a clue that perhaps the TIF response is not so good. And so you have this one unidirectional cancer to myositis, but I'm not ruling out the fact that somehow once you get that immune response, it actually may be abetting tumors. Remember, we're probably having tumors, unfortunately, that are kind of popping up all over, right? And if you start to decrease your ability to block that tumor, and you might ask, well, we immunosuppress people, why aren't they getting tumors pop up all the way? But there's something very specific about, there may be something very specific about an anti-TIF response that's worse than immunosuppression. Let's see. So I think I just wanted to finish with screening because this comes up clinically. Well, okay, that's a great story, but so what do you do? So a patient comes in, do I screen them or not? And who do I screen? How do I screen? When do I screen? So this is probably the clinical slide that's helpful. And these are the risk factors that have been shown in multiple studies to be associated with cancer-associated DM. So first of all, having DM rather than another myopathy, okay? Being older. So I don't think this is old anymore. I think this is pretty dang young, 45, 50. Male, so I'm fitting both those so far. Anti-synthetase, so if you have an anti-synthetase antibody, yeah, you might be at a little bit lower relative risk relative to the other DM serotypes. Certainly TIF gamma puts you in a risk factor. And then these are some of the softer things. I'll just mention one paper that we have that's coming out is this ulceration issue. The issue of ulcers is actually really fascinating in DM. And I think as dermatologists, if you're examining a DM patient, there's one thing you should look for, and that is just any evidence of crusting or ulceration, because that can really help you. If you find that's a TIF gamma patient, and you see they're presenting with crusts and ulcers, not just from scratching, but it's a erosive disease, that's like cancer till proven otherwise. They have you've got to go find that cancer. But if you come in, you've got palmar papules and you've got ulcers, well, that's MDA5 disease. That doesn't mean you have cancer. That's a totally different thing. So the ulcer means something different in the MDA5 group than the TIF group. And then there's another, I don't have time to talk about, there's another serotype called NXP2, whereas those patients, when they get ulcers, we used to start looking for cancers all over the place. They don't get the ulcer, those patients don't have cancer, but it just is an indicator of really, really severe myositis disease. Those are the patients who end up in the hospital. They often need like feed tubes, things like that. So ulcers mean different things, I guess is my point, in a DM patient, depending on the serologic background. All right, so you have these clinical risk factors, and then this is just a publication, I think Rick might have shown this, but where the concept here is, okay, we're just gonna stratify, right? That's all about stratifying patient risk, right? Is this low risk, medium, how at risk is this patient for cancer? And the authors came up with some, I'm one of the authors, but it's a little arbitrary, like okay, so we need some data. We don't have data, but so maybe if they have one protective factor, they're low risk. Sorry, if they have no clinical risk factors and more than one protective factor, then they're low risk. And then you can imagine intermediate and high risk. And then maybe you screen according to that risk. Low risk maybe you're just age appropriate. Maybe you scoot the colonoscopy or mammography down. If you have a 45-year-old, you're going to do a colo, or you're going to do it. But this is all a little bit just kind of playing it. It's off the cuff. That we don't know. Enhance, maybe if you're intermediate risk, that's when you scan people, okay? And I know Tony loves CT scans for everyone, so being facetious. But yeah, clearly, scanning everyone is not a benign thing, right? That's going to cause all kind of downstream stuff you're going to have to deal with. So, so I think, you know, and maybe you do a PET CT for someone that's really high risk. But the bottom line is we don't know. And so you can ask me how I screen my patients, but who cares how I screen? That's just, I mean, that's just how I do it. But you know, it's how we do it. I think we're much better for being driven by data and by serology, right? And so I'm going to argue this, and I'm going to say, think about cancer-associated rheumatic disease as two groups. There's the synchronous group when the disease and the cancer come up, and then there's the late cancer group. These guys, when you see them, those are the people who just have fulminant onset, right? They come into your office, and you're like, whoa, new dermatomyositis, right? And you always got to think about 50 different things, like, do they have cancer? What am I going to treat them with? Do they have myositis? Those are the patients where, you know, we want to know, how deeply do I screen this person right now? Like, does this person need a CT scan, right? Whereas this kind of issue is more an issue of, do I need to rescreen this patient ever? And so I would argue that these protective antibodies may be helpful for the rescreening issue. If you have none of, once we feel like we've saturated the system and we know we can identify most of the protective antigens, and you don't have any of them, that's going to put you in this group. And so that's the person, if it's early in disease, I'm gonna give them everything. I'm gonna CT them, I'm gonna do it because the risk is gonna be higher. So just so you know, we're doing this now. It was a large collaborative study we're actually doing this experiment and saying, can we come up with an algorithm where you layer on these serologies, and I can say you have X risk of getting a tumor within, you know, X amount of years. So, and I believe these patients can be identified immunologically, or certainly we can do a better job. Because people come to me and they say, well, these autoantibodies are not that helpful. I mean, what, TIF gamma, that's not, and my answer is, well, yeah, because you haven't done a detailed enough analysis yet, right? TIF gamma, yeah, a quarter of them are going to get cancer. How do I know? So I've gone from 15%, which is the overall DM percent of cancer, to 25% by getting that test in the U.S. So it hasn't given me a lot, right? The TIF doesn't really give you a lot as far as where to go to with screening. Okay, so just to finish, so the connection between DM cancer is still very unclear. I think it's getting clearer that it relates to anti-tumor immunity. It may not be unidirectional. It may be bidirectional between the immune system and the tumor, but the immune system is almost surely a link. DM cancer in whom the cancer doesn't emerge, they have a more diverse autoantibody response. That was what the gel I showed you. Many of these antibodies, 2 of them are named that we are getting more press, but there's others that are associated with decreased cancer emergence. In the US, these are US patients. I don't know what happens in Japan. One thing that's interesting, I mentioned that TIF gamma patients, right? If you have TIF gamma and you're Japanese, your chance of cancer is much higher than in the US. All the Japanese patients that we've looked for these antigens, very rarely do these Japanese patients express autoantibodies against these protective antigens. So that may be an explanation why maybe all the Japanese are focusing on TIF and they can't spread their immune response. It might be HLA, it might be, you know, most likely it's HLA, but that might explain that. The timing of and the utility of broad cancer screening is still totally not well defined. It's really going to be, you know, certainly I'm not going to broadly screen if a patient comes in and they've had DM for 5 years. You know, I'm not going to screen that patient for cancer. Cancer risk stratification is relatively crude, and I think the image phenotyping can help. And then I just want to acknowledge all the serology group and the other cohort is at Johns Hopkins. These are the folks, Olivia Casciola-Rosen, who does most of the serotyping and antigen discovery, and her husband, Anthony, who's brilliant. And then my clinical collaborators, Lori Chung, who does the Rheum Derm clinic with me, Matt Lewis, a fantastic dermatologist from Rochester. And then again, I'm thanking our patients much as Dr. Kallenberg did, because literally all those little tubes of blood that we drew from 2002, 3, 4, 5, 6, 7, that we didn't know what we were going to do, we finally have use for them. And most of the patients forgot that they donated it, you know. But then we tell them the story. Hey, did you know you have this? And they like to hear it. They're very interested to hear that they have evidence of a cancer response. All right, so I'll finish there. Sorry for the long talk.
Thanks, Dave. Questions? Dr. Edelson.
David, have you thought about screening at the T cell level for TIF1 gamma immunity? Because it would actually be interesting and easy to do.
Yes. Yeah, so that's a great point. We thought about it for a long time, but we didn't do anything about it for a long time. So we're finally now just doing TCR repertoire sequencing in the skin. And then there are ways once you have the sequence data that you can fish for the antigens. Basically, we're working with a company that can do that.
There's an easier way. So
Talk to me.
you know the structure of TIF1 gamma. So it would be very easy to either add the protein to our dendritic cells and then do an ELISpot with those patients' T cells.
Yes, sorry. I was trying to say that we want to also be able to identify the receptor that binds. So,
But it may be that the anti-tumor immunity is more T cell mediated, and maybe the humoral immunity is more autoimmunity. In other words, cancer immunity may be T cell.
Yep. We don't see T cells in the skin, right, very much in DM.
But
we don't see B cells, sorry. We don't see B cells in the skin in DM. We see T cells. So
they may have finished the job.
They may be presenting to the T cell or whatever. Yeah, so I think we haven't not even done that experiment where we're basically just take the antigen, chew it up, and feed it in just like an MLR, just in a mixed lymphocyte and just see if they have cells. Or an ELISpot.
Just put it into easy to make physiologic dendritic cells. We do it all the time. We can talk.
That would be awesome.
Thanks very much for the great talk. Fantastic.
Thank you.
I have a naive question because I'm not expert in this, so I probably will say something stupid. But you mentioned in the DM patients, only a small fraction have cancer, and the mystery is majority of them do not have cancer. But we have been looking at the patients as binary, that have cancer or that do not have cancer. Right. But even for the patients who do not have cancer, they're not normal. As we age, we all accumulate somatic mutations in our tissues. We and many other groups have been studying this. We have shown in sun-exposed skin, there are lots of mutations, and in P53, Notch1, and many of these mutations happens at exactly the same spot as in cancers, recurrent hotspot in cancers. And we also show they rarely happen in the non-sun-exposed area. So these mutations are kind of like elephant in the room. And we have seen data, the clones harboring these mutations can get very large in size. They're just invisible. Mm-hmm. Histologically, they look normal. But if you think about this, they can have direct or indirect contributions. They can directly affect the function of keratinocytes. And also, they produce new antigens, same as the tumors, and which can chronically irritate or prime the immune system, which contribute to the later events. Right. Since right now, the technology has been advanced that we can detect this mutation pretty accurately. Do you know if anyone has looked at that? Because I know most of the focus has been on the autoimmune part, but right. Yeah, these are new antigens.
No, great question. It's something we've thought about, right? Why does it always have to be a cancer, right? Yeah. I don't know that it has to be a cancer all the time. You could argue maybe it does. Maybe there's something about it being cancerous, truly, like, that it's there's certain signals that are important to cause this immune response. But I am completely agnostic, and I think anything that could become immunogenic, right, could potentially cause autoimmunity. And so I think, I don't know if you're talking about like detecting these by circulating, free circulating DNA or you're talking about going to the tissue. Yeah, going to the tissue. Yeah, so I think that would be interesting. I'll just say that when we search the antigens, okay, when we screen these patients' antibodies and we mass spec them and we look for everything, we don't find your typical like P53, RB, all these, but that doesn't mean that there's not other things that could be being mutated in these, whatever you're going to call them, I don't know, precancerous or mutated. So I think it's definitely possible. If you can think about a way to study that, maybe that would be very interesting. One thing I'll just say is that we did, there are certain things that are like precancerous that are relatively common that we can look at. There's these pancreatic cysts called IPMNs, intraductal pancreatic mucinous neoplasms. I don't know, do you guys know what I'm talking about? These IPMNs, yeah. So anyway, they're kind of precancerous. They often become, not often, they can become cancerous. And so we had the hypothesis maybe like the immune system could also react to those kinds of things. But if you look for IPMNs, they're no more common in the TIF group than in the non-TIF group. So IPMNs, we struck out on that one, but that was like one type of pre-cancer. And so that, I think it's a great point. And
yeah, given that we know DM is related to UV exposure, because I was particularly thinking about the precancer in the skin.
In the skin, yeah. I see. Yeah, if you have, I mean, I don't know if there must be are there hotspots or certain genes that tend to be mutated, and you know, we'd love to see what those are, and we can start to screen and see if we're getting those more often than we'd expect by chance, you know, because we have the mass spec reads, right? So we have all this. All we have to do is just look for them in the list and then verify that they're making immune responses against these. Yeah. So if you want, you know, yeah. So that's very interesting.
Yeah. We have paper published for that.
Okay.
Yeah, we can talk afterwards.
Yeah. Okay.
Thanks.
Thanks for a great lecture. My name's Justin. I'm one of the residents here at the clinic.
Awesome. Thanks for staying till late.
You're welcome. You already answered 3 of my 4 questions, which was who to screen, to what extent to screen, and when to rescreen. I was curious if on the horizon you think some of the expanded serological testing will become commercially available for us to use as clinicians, and if that will help, you know, guide that question of who to screen and to what extent to screen.
I mean, I think that's almost an elephant. It's almost embarrassing that it's not, right? I mean, it's embarrassing that you can't even get a good test for TIF. I mean, I hate to say that. Well, you can. There is one place that can give a good test, and that's the Oklahoma Medical Research Foundation. You know, a lot of these, I'm not going to name them, but they come from institutions that sound like they should be very good medical institutions, and they're doggy doo-doo. So because we've looked at them, we've compared the sera from our tests to what they read out as, and they're false positives, false negatives. Like you almost can't even, it's almost a worthless test. So, so the question is, yeah, first of all, when are we going to get good tests for those, for the common ones, for the ones we've known about for 15 years? My hope is that we will. I don't know, you know, I don't control those forces that decide if they're going to pick up and decide that it's worth trying to market a test because they think they've got enough business to make a diagnostic, you know, to actually make it worth their while. But, you know, there are people working on this in terms of collaborative efforts in the myositis community trying to figure out, okay, what's the gold standard way that we at least have to come up with, say, what is the goal, what's a gold standard that's realistic? IP is too hard, immunoprecipitation, right? So what is it going to be? And then can we standardize that? But it's a process. Think about the ANA. Have we still figured that out yet? I mean, you know, you still send if you send an ANA to one place, they do it by a bead, right? You send it on to another place, they do it on an immunofluorescence on a Hep2 cell. I mean, they're totally different tests, and yet we still haven't standardized that test. And it's only been around for, what is it, 70 years, something like that? So I'm not sure I have high hopes, to be totally honest with you. I think we've gotten lucky with the antigens that are easy to test for. Like there are certain, like whatever, Joe1, Rho 52, so ones where you can make an ELISA and everyone just does it because you can fall off a log to find that antigen, right, to find that antibody. But the other ones, I'm actually not so sure we're ever going to get there. I hate to say it.
Thank you.
Just send everyone to me. I'm just kidding.
Sounds great. So we talked about DM occurring at the time of cancer and occurring, or DM occurring and then cancer later. For that group of patients that might have the cancer first, and then there's a delay, what do their autoantibodies look like? And if, say, DM comes up around the 3-year point, are you starting the screening similar to a new patient?
Like they have a new maybe
exactly,
they have a new
or
one.
you know, if their oncology team feels confident that their, you know, disease is still in remission, do you say, well, I think you should take an extra look or, you know, follow this patient in a different way?
Yeah, so the question's about what about antecedent cancers? How do you deal with that? The model kind of makes sense for a cancer that emerges late, right? You can see how that would happen, right? If the immune system's just keeping it in check. But for a cancer that occurs 3 years before the DM, especially a cancer that occurs 3 years and is treated, and we think it's gone, and then yet they get DM. I don't know what the model, that doesn't make any sense to me, unless it's taking so many steps for that autoimmune response to finally emerge. It started 3 years ago. But the answer is, so if the patient has an active cancer, you know what I mean? Like I'm thinking, well, this wasn't a curable cancer. It wasn't stage 1A or stage 0 3 years ago. I'm not 100% sure if I know you're oncologist, everyone says you're doing well, but I'm gonna pretty much assume that's the cancer. And I'm gonna probably suggest to the oncologist that we take a look and make sure we do a PET or something to make sure something hasn't changed. So I'm basically rescreening. In the patient who had ductal carcinoma in situ or something like that, right, 3 years ago, I don't have a model for that. So we tend to screen. So I'm gonna be thinking there may be another cancer, but we're a little bit in the dark, just like you, as far as like what do we do about rescreening, in the past. But certainly I tend to give it the benefit of the doubt. I tend to think, okay, I need to rescreen. I'm not going to assume that cancer, even if it's cancer related, is the cancer. So the most I'll do is assume it might be the cancer, but I'm still going to look for it more aggressively. I'm not just going to say, oh, we found the cancer and it's gone now. Great. So the worst scenario, right, is a patient who has a history of cancer and new onset DM. That is like cancer to me, like that cancer is very high chance that cancer's recurred. I had a woman, this is very interesting, she was 48 and got new onset DM, had a history of Hodgkin's disease at the age of 17. Cured. 17. I told her I found her oncologist. The oncologist didn't even remember her. He said, no, that's crazy. That never would happen. You wouldn't have a recurrence. I said, can you just scan her? Recurrence of Hodgkin's disease. So that's just an example of probably the same tumor that was just in equilibrium for so long, because it had the same marker. It was the same tumor.
Yeah, I have a male patient, had testicular cancer, treated, and then a few years later developed DM, and no evidence of any sort of recurrence. But I'm just, as you were talking,
I would be really
talking
worried
about,
and the fact that you don't find it, don't be, because now you have this concept of equilibrium, right? Like, okay, it could still be there. So I have to just be vigilant and always have in my mind, maybe I'm going to pick the IVIG instead of the CellCept if I have a choice. Yeah.
Okay, thank you.
Dave, I'm trying to understand how you interpret the immune response in those autoantibodies. I guess when I first read your JCI paper, my impression was that what you were interpreting was it was really how robust the immune response was to the cancer that dictates whether it will emerge or not. But I'm trying to rationalize that in the context of you're seeing very specific autoantibodies in addition to TIF1, CCAR1, SP4. So do you think it's a specific immune response? And you get those autoantibodies regardless of the type of malignancy, right?
Right.
So that
Well,
I'm just trying to, or is it both?
Sorry, are you asking me, is it a general tumor response, or are there going to be very specific antigens that are protective?
So do you think there's something, it's important to have these specific autoantibodies, or is it just for some reason you think it's a robust immune response, but for some reason, if you develop TIF1 gamma autoantibodies, if the immune response is robust, regardless of the type of tumor, you get CCAR1 autoantibodies, you get SP4.
Right. Yeah, I think what you're asking is this just a marker of a good cancer response, or is this actually, is this actually the good cancer response?
Yes.
And we don't know. I mean, right? We just know that it's associated. When you see a dirty gel, that's a good thing for the patient. There's more and more evidence. I'll just say that I mentioned way at the beginning these autoantigens, right? It's interesting because they're these universal autoantigens. They're expressed in every cell type, right? So how the hell are you getting dermatomyositis when you? There's definitely some tantalizing data that these antibodies actually go into the cells. And so our dogma that you learn, right, in immunology is that antibodies do not go into cells. So everyone would always ask me, who cares about these antibodies? Like, you know, because antibodies, the immune system only sees what's on the surface, right? It only sees what's outside the cell. That may be how you initiate the response, you know, by antigen presentation, but if you look at TIFF, there's a publication that they looked at TIFF, or you look at MDA5, you can find that an antibody in the cell that's localized exactly where that antigen is, inside the cell, and you don't see it in the patients who don't make that immune response. That's in the muscle, just so you know. So I think it's possible that CCAR, which is involved in tumor growth, and regulating apoptosis, that antibody could literally be blocking CCAR. I mean, it's possible that it could be blocking CCAR function that's directly anti-tumor, right? So my sense of it is that there's this hub of antigens. It may be one structure. I don't know. I think of them physically, like they're in a structure. That's what I think is happening. So it's not, I don't think it's infinite, but they may be just marking something that's indicating that there's been a really, really good response. I can't tell the difference, obviously. That's gonna, yeah.
And then you mentioned your cutaneous ulceration.
Yeah, cutaneous ulcers.
Yes, is a marker, and erosion or crust is a clinical marker of underlying malignancy. So do you think that you can get any clues from the skin in biopsies, looking at certain cell types, that could predict underlying malignancy? Not that it would ever be better than serology.
Great question.
Okay.
Do I think that? It's possible, like that. The ulceration may not be. I don't know. I think we need to understand, like, how do you still get from tumor to skin? Like, you're making TIFF-Rhum response, right, in the tumor, presumably, and then how does that give you skin disease? What is it about the biology of the skin that allows the immune system to keep propagating that response, right? And it doesn't happen in the in the joint or whatever, so why is that? So if you generate a TIFF immune response from a cancer versus sunlight, is that going to look different in the skin? I mean, it's a great question. I think it's possible, right? I know I'm just saying everything's possible, but I'm trying not to close off, like I don't know. Yeah. But we had to start somewhere with a framework, right? If we have no framework, we couldn't even try to make hypotheses to test to see that this data is consistent. All I can say is our data so far is consistent with that that the tumor response comes first, and these are protective add-on immune responses. Yeah.
One last question for Dr. Fiorentino?
Thank you. For those patients with the tumors associated with the dermatomyositis, well known, and then it was treated successfully, does the dermatomyositis go away, like that patient with the uterine cancer that you showed?
Good question. Yeah. The answer is usually, in my experience, not. But for sure, there are patients where when you treat the tumor, the disease can dissolve. So we think our data is maybe showing that if you're a TIFF and you have a tumor, and you treat the tumor, then the tumor is more likely to go away than if you're not TIFF-associated cancer and tumor and you treat the tumor. But even then, it's not 100%. So great question. I think what happens is, right, it's kind of the match fire thing like Rick was saying. If you may have started with the tumor, right, but the immune response is unbelievable at propagating and finding its own fire, right? So once it's got propagated to the skin and the muscle, presumably it's got its own tinder at that point. So putting out the original tumor, I'm actually surprised it ever goes away, to be honest with you, but it does. I've had patients where it dissolves, and then you really look like a hero. The most heroic you can look is when they come in, they have a rash. The other dermatologist said they have contact dermatitis. You said, we need to screen you for cancer. They said, what? You find an ovarian cancer, you treat the ovarian cancer, you cure them of ovarian cancer and their rash. Like, right? That's when they really think that. That's happened like once in my career. I think I was a third-year resident. I thought, this is really cool. This is going to be great.
Dave, thank you very
Yeah,
much.
okay, great.
Please thank all of our presenters. I mean, the discoveries that we've heard this afternoon by these 4 physicians are just unbelievable, and pave the way for discoveries that have already been made and future discoveries. Thank you all for staying. And we have a lot more education tomorrow, so we'll see you tomorrow morning.